So we are live now.
We welcome you all back to Chapter 8 of the Youthful web series under the aegis of IIRSI. Today's topic is one of the most challenging topics on in on the correct laser beam. Our aim at the end of the session is that we know how to select the correct patient and select an accurate choice of refractive platform for your practice. We have with us refractive pioneers who will shed light on this topic. We welcome our IIRSI President, Dr. Himanshu Mehta, to inaugurate the session.
Good evening, friends. Thank you, Pooja. And thank you, panel. Dr. Vinodara, thank you for being there. Rohan, Nikhil, Anshika, Ashok, Dr. Wadman, everybody. Good evening and thank you all for being there. Friends, as you know, that refractive surgery is an essential part of modern medicine today. Cataract surgery itself has become refractive surgery. It's no longer the good old cataract surgery which is there. It is refractive surgery. So every anterior segment surgeon unquestionably should be doing refractive surgery. There is no doubt in my mind about that. If you can do a chalazion, then you can definitely do a LASIK surgery. Have that confidence. You'll be able to go ahead. You just need to have a little push in life. You need to read up, do your homework well. You have fantastic machines to support your full infrastructure. The topography machines have changed and the newer Schlemmflug has really helped us understand the anterior cornea and the posterior cornea. All that you see right now and you're going to be hearing in the next hour or so should encourage you to start refractive practice as early as possible. Because if you're not, because there are a lot of people, I saw a lot of students of mine who said, I don't get refractive patients. I don't get patients who want LASIK. This is absolutely wrong. You start doing it and you will suddenly see patients increasing. You could suggest in the beginning, but unless you start, the ball starts rolling, you will not be able to invite patients, because if you don't do it, the word will spread that you are not doing it. So there is no reason for anybody not to do refractive surgery. It is an essential part of your private practice. You're missing out a lot of stuff. It's like giving intravitreal injection. You cannot miss. A general ophthalmologist cannot miss giving intravitreal injection. Same way, refractive practice. Well, whether LASIK, whether PRK, whether the femto LASIK or a microkeratome, or is a smile better? And of course, all those patients who are not good for any of these refractive procedures, you have ICL, implantable columnar lenses, the ICL, the IPCL. Lots of work has been done across the world on this, and you have huge pioneers in this country. You have fantastic results. And all those patients who are above minus 10, 15, 20, 25, who you thought were inoperable, you can see the happiness on their face. It's a phenomenal change in their quality of life, their confidence, and their approach to the society. And this is not a small percentage of population. Mind you, refractive surgery can be a huge number of patients for you. And as more and more surgeons start doing it and more patients start accepting it, what resistance, Dr. Arora, we faced 10, 15 years back, and what it is today, is there is an amazing difference. Patients have started accepting. Earlier, there used to be, kisne kya hai, malum nahi hai, kya hota hai, how many eyes are lost, what is this? So 20 years back, it was like an enigma. You had to break through like flax, femtolaser assisted cataract surgery. You had to tell patients 5 years back, but now patients are asking. So the sooner you dive into it, the better it is. ICL, IPCL, LASIK, femto, PRK, there is a huge armamentarium. And believe me, it's not a big learning curve. And that is a very important part of your practice. You take care of a few things, and the cornea is generally very surgeon friendly. So if you know where not to do it, which is less than 2% of your population, rest all places you could apply your knowledge and do it. So we have a very interesting sessions and some very, very important speakers to enlighten us this evening. Back to you guys, and thank you for objectively pacing it for the youthful, the younger generation who are still confused coming out of residency fellowship, what kind of practice to do. So thank you for organizing that.
Thank you so much, sir. It gives me immense pleasure now to introduce our next speaker, The first speaker for the evening is the President-elect of IIRSI, Dr. Vinod Arora. A refractive pioneer in North India, he is the chairman of Navjyoti Eye Hospital in Dehradun. He has given multiple national and international talks. Dr. Arora also has over 50 research publications to his name. We have him on our show to speak about microkeratome versus femtosecond, start small and grow. Over to you, sir.
Thank you so much, Rohan. Let me share my screen first. Where are my PPTs? Just a minute. Oh, I have to stop it. So LASIK, as Dr. Mehta has rightly pointed out, has become now the part of our armamentarium. So you can't avoid it, you can't ignore it, at least I can say. If you don't have LASIK center, you have to have a tie-up with somewhere, or it's better to start your own, or you can have a group practice. That depends on various factors. Are my slides visible?
Yes, sir.
Okay, thank you. So once you're going to start practice, the question comes, we have got a lot of options with us. We have got microkeratome, femtosecond, we have got SMILE, we have got advanced surface ablation. So how to start our practice and how to grow it? Since LASIK surgery is a high investment area, the equipments are very costly, the maintenance is very costly, the CMC is very costly, the per procedure charges are also very expensive. So how to start it? Should we get everything at the beginning? I think it's not advisable if you are not born with a silver spoon. So since it's a hard-earned money, you have to invest wisely and you have to look for the return also. So we are going to start with the basic concept. So what is LASIK? LASIK is creating the flap. It's a three-step procedure basically. So first you have to create a flap. The flap can be created by many ways. Then you do the excimer laser ablation and you reposition the flap. So this is a very basic, simple things, and you can easily learn it. The learning curve is very, very small, but you have to see the fine nuances of the thing. You have to be very, very aware of those things. It's not the surgical process, it's more of the machines. But you have to know your machines well. You have to know the finer things very, very well. So let us start with the corneal refractive surgery. It can be mechanical. We have M2 keratome, or we have SBK, or we have other keratomes now. These are mechanical devices which can create flap. Then we have laser also, which can create the flap instead of mechanical devices. It's called the femtosecond laser. Then there are procedures like flapless procedure is SMILE, and flapless and capless procedure that is called advanced surface ablation. So there are a lot of things our surgical armamentarium. I'll just cover the first two parts, and the second two parts will be covered by subsequent speakers. So basically, we have to understand what is a mechanical keratome is. So it's a sort of instrument which causes pressure on the cornea, which causes flattening on the cornea. A blade is there. This is an oscillating blade. It keeps on moving or oscillating, and it creates a flap. So I have done most experience is on Moria, M2 and SPK. So I'll be discussing more on that. M2 is now not more used. If you're going to buy new one, go for the SBK. That is much advanced with much better capabilities. So these are various types of microchromes that's available in the market. You can use any one, but be careful that it should have good record and it should have good service also. That's very, very important. Because once you buy an instrument, you have to be very sure that you get a good service also. So buy from a reliable dealer and go for an instrument you want to have a small training and have the feel of this thing. I think Moria is one of the very leading in this field, and I have used it extensively. So I'll be covering of that one also. This is how we place a suction ring on the cornea. It creates a suction. Then we move the microkeratome. Microkeratome has a oscillating blade in it. So it gives a cleaner cut. And there's a hinge on the last. We don't do a free flap sort of thing. There's a hinge there and the flap, it comes back. Then the laser procedure is done. Once our ablation is over, so we do a desired ablation with using a excimer laser. And this flap is reverted back. It should be aligned properly. Normally it aligns itself because of the anatomical reason, but you have to make sure it's aligned well. So it's a very simple procedure. You just see it one, you'll see it's just peanuts. But there are complications with every procedures. Of course, the complications are not common, but it's my duty to inform you about the complication also, because anything you are going to do, maybe it's smile, advanced ablation, maybe laser, femtolasic, but complications are with every process. Of course, the incidence keeps on decreasing once you improve the technology. But once you're going to start a surgery, you have to know the complication first. If you're going to drive a car, you know where the brake is. So you can just avoid them. And if happens, you can just manage them. So incomplete cut can occur there. I'll not go because the time is limited given to me. So it's not possible to cover all the procedure, but it can occur because of loss of section, or is there a block of keratome by drape, or there is a power failure. So there can be buttonholing. Some tissue may be left there. You have taken a flap, but it's not a complete flap. There is a button of the epithelium remain there. Then there may be free cap. It may be because of various reasons, but free cap can be again managed, but you have to be careful in which corneas it can happen. Then striations can be occur there. It can be micro striation or maybe macro striations there may be there. So what are the flap complications which are common with the microchrome? It may be displacement of flap. It may be wrinkled flap. There will be micro or macro striations. It may be interface debris there, which can cause a lot of inflammation. Then flap edema may be there because of the excessive hydration. Then flap shrinkage may be there. If you let the flap there drying for a long period, then it can cause shrinkage of the flap also. Then flap stretching may be there, or maybe decentration. While you're making flap, it may not be central also. So it's not a scope to cover all the complications, but we'll just quickly move over to femtosecond LASIK flap. So these are the various machines which are available, and they're all very good. You can make it very precise, very accurate flap by using these machines. Instead of mechanical things where you're not very sure about the many things, you can customize so many things here. I've used a lot of IFS 150 intralace, so I'll be talking more about that. There's no special protocol. Whatever you're doing in the LASIK, same you have to do here. Preoperative examination, workup, and surgical planning is almost same. So what happens in intralace? Basically, we make it in two parts. First is a horizontal cut, that's called the lamellar resection. Then there is a side cut, which comes like making for flap. And pocket is an optional resection used as a vent for bubbles to evacuate because it creates a lot of bubble. We know the femtosecond cleavage of the layers with the creation of carbon dioxide. This causes cleavage. So this gas has to go somewhere. So we provide a vent in the form of pocket. So each resection has its own set of parameters. We can finally preset how much the thickness we want, how much should be the side cuts there, how much should be the hinge there. So all these can be pre-programmed, pre-planned. This is the pattern we got. We got basically two types of pattern. It's called the raster pattern, where the movements like this and it keeps on moving this, right? Second is a spiral pattern where the starts in the center and that's gradually comes from the periphery. So pocket is, I just told you, because it is required. The beauty is this pocket is slightly out of our treatment area, and all gas comes to this pocket and is being absorbed there. So it's a releasing vent. It causes decrease in the chances of opaque bubble formation. And we have side cut only features also. In some cases, we require side cut also. Suppose we have to do retreatment, or we have just somehow got suction loss or something there, we can do side cut options only there. So this is just to compare the both process. In microchrome, we mark because there is chance of sometime free flap also. But in femto, you don't require. We place a suction ring in both the system. After the suction is microchrome is much higher than compared to femtosecond laser. This laser is now creating a planar flap. It's a horizontal resection being done. In microchrome, we adjust microchrome head in the groove and it slides itself forward, creating a flap. It takes back. Now the flap is created. Once is the femtosecond lasik flap, second is the mechanical or microcontrolled flap. So the process is almost same. Only thing femtosecond provides us more of automation. And naturally, after the laser treatment, we have to reposition the flap. The technique is almost same. Only thing difference between the two techniques is creation of flap by a laser, and second is creation of flap by a mechanical method. So what is the difference between the two? Since both the things, they are doing the same thing. We are not adding anything or changing any feature, except we are creating flap with a laser structure. So basically, we know that on the cornea, peripheral fibers contribute to strength. These are very, very important. And minimize cutting on the deeper fibers can be occurred. So microkeratome doesn't cut in a very straight way. It causes something like this. It's a wavy that's deep in the periphery with poor diameter, and centration control are not there. While with femtolaser, we just got a planar flap. Its thickness is almost same everywhere. The side cuts are made. So this is a OCT of a femtoflap. We intended to have a 90 micron, and we can see it's 90 micron everywhere, almost 90 micron everywhere. But once we do a microkeratome, we intended to do a 160 micron flap. Of course, we don't do like this now, maybe around 100, even 90 micron or 120 micron, 130 microns. This we are using nowadays. But for the sake of clarity, I just have this slide. So we can see the variability here, the 179, here the 155. So there's a lot of variability between the thickness of flap. It's not a planar flap. Second advantage with femtolaser is that the hinge is outside optical zone. So it's a 8 millimeter area, but we got a lot of optical zone that's much clear. Hinge is not interfering. It's a 9 millimeter zone, but hinge is interfering here. So we get a clear area, which is very less compared to a femtolaser. So it's like a D-shaped incision is there. Hinge is interfering. So we can't do ablation on this area. We have to choose the central area only. So we get a less area when we use a microkeratome compared to femtolaser. Then there is another option. We can have elliptical flap also. Suppose you got a cylindrical number at 180 degree. Naturally, the ablation is going to be more on that axis. So we can have a elliptical area. That means this area is increased on that side. So our hinge goes little away from this place, and we got a much bigger area than we got in a round ablation, a round flap, if we may. The another advantage of femtosecond LASIK is that we can adjust this flap inside. That means beveled in. Instead of going instead of keeping flap on the top, the flap edge go inside. So it provides much better strength to the flap. There's less chances of displacement, and overall strength of biomechanical stability also increases. So that's the advantage. In this case, we can choose up to 150 degree of this bevel, while in microkeratome, it is less than 90, maybe 70, maybe 30, 45. So that causes slippage of the flap is much more common in microkeratome, but here is the much provided strength, and it also provides a strength to the flap also. So our biomechanicals, that also improves a lot. So post-operative regime in femtolaser, since we are using a laser energy also, so it uses a little stronger steroid. Rest, that too initially for 24 to 48 hours, but the rest of the post-operative regime is unchanged from the standard LASIK post-operative care. Same care we have to do here. So what are the advantages with femtolaser? There's enhanced flap customization. We can customize size, we can customize thickness of the flap, and we can position the hinge. We can have it on nasal, this temporal side. We can have it in horizontal side. Even we can make on the lower side also. Not on the nasal side, but all other three sides. But in microkeratome, we have got a fix. Either we can make it on the horizontal, or we can make in a top temporal side only. So we can't change in between, but here we got option, we can change wherever we want to have our hinge. Then flap is more biomechanically stable. And of course, we can have option of side cut angles we can change, and we can have the elliptical flaps. Faster visual recovery that occurs in both basically, but it's much better healed. Then exceptional safety. There's a lot of safety in femtolisic. The reason is, if anything goes wrong, suppose there is a suction loss or there is any problem, you can just stop the procedure and then redo it. Except one or two things, you can always redo the procedure. While in microtomy, if anything goes wrong, most of the time you have to abandon the procedure and have to do in a later stage. Either you do advanced surface ablation or a lot of things there if complication occurs there. Meanwhile, we have to discuss also some of the complications of femtolisic. It's not a complication free. Of course, the complications are much, much smaller if you compare to microkeratome, and most of them are manageable. I just name them since we have to cover in short time. So it's a very safe procedure. LASIK, we know, very safe procedure, and femto added become much more safer. But we have to be ready for complication also. We should know about that. The best thing is the preparedness. Subconjunctival hemorrhage is very, very common. It's not a complication for us, but it's a complication for patient. So you have to tell the patient in advance that there may be subconjunctival hemorrhage. There may be red spot that may persist even up to 20 to 25 days. Sometimes the patient gets alarmed by this thing because they can see only this thing. So you have to just foretell them that that will be there. So there's nothing to worry about this thing. Then there may be damaged applanation cone. Of course, we have to observe it well. There may be debris on the applanation cone. We have to take care for that. Then, like any refractive procedure, there may be complications, like there may be suction loss. That can occur in microkeratome also, but here also. The only advantage is there, we can redo it in the same sitting. We just take out the things, we adjust the parameters, and we restart the process. So we can, if there is suction loss, we can always redo it. Then vertical gas back through is the thing, is the only thing where we have to abandon the process. And because it's a sort of reverse of buttonhole. That means there is a hole in the flap and the gas comes out from that flap. So we can't do on that one. We just leave the flap there because everything is intact. It's not a flap yet. We have not lifted it. We leave it everything there, let that thing heal. And after some time, we can do the advanced surface ablation. Horizontal gas throw is common if you do it on your flap goes to the outer boundaries. I mean to say it's very close to limbus. Then there may be horizontal gas breakthrough. If you can ask the patient to wait for half an hour. Suppose you got a session, you do 4 or 5 cases. By that time, it's most of the time it absorbs. And if there is a very small gas, it's not going to gas bubble. It's not going to interfere with your procedure. Opaque bubble layer is very, very common in femtolisic. It's as a rule it occurs, and usually it clears up within few minutes. If there is hard ovule, it may take a little more time, but we have to change the parameters if we are getting it repeatedly. So we can change the parameters and it can be corrected. Applanation technique is called a soft applanation technique. Bubbles I just discussed you. If there is a bubble, we have to, if it's too much, then it may interfere with your treatment. If there is a single bubble or two, then you can go ahead. But otherwise, you have to wait for half an hour, it will go off. Hinge tear is not common, but can very rarely occur. Then decenter flap can occur if your eyes is moved or the patient is not very cooperative. But the advantage is here, if the flap decentration is a little bit, it's not going to cause you any refractive surprises or any change. Unlike a smile, if there is a little decentration, then there will be change in the refraction also. But here, since the flap is not contributing to the refraction, so it's not going to matter much. If it's too decentered, then you can do it in another way. I mean to say you can redo it and make it central. Since everything is there intact, epithelium is there, flap is not lifted, so there's no change, you can always do it again. So that's the beauty of femtosecond laser, that it forgives your complication also, and you can manage them also. But that's not possible with the mechanical keratome. So just to sum up, this is a more precise flap. There may be chances of elliptic. There advantage of elliptical flap. Their choice of hinge position. Then inverted side cut. That means beveled end. You can make it there. So just comparing the two things. If we compare both the things, the learning curve in microkeratome is a little short. In femtosecond, it's a little longer, but not too much. You have to learn the few tricks and you can master the things. Then customization in microchrome is limited, while it's fully customizable in femtosecond laser. A lot of variations there. It's a fixed thickness. You can use 90 micron, 130 microns. You get a fixed blades. So you can't change it. You want to have 100, it's not possible. Then hinge position is fixed. Either you can have temporal or you can have superior, while in femtosecond you can have superior, temporal or nasal, whatever you want. Or edge lie on the blade, that means bevel out. In femto, it's a bevel in. That's a more mechanically stronger condition. Then the size of flap is a limited choice. You have to choose the various rings, and only those rings can be used. And you have a limited choice. But in this, you can customize the flap size. You want to have 9 millimeter, you can do it. You want to have 9.15 or 9.25, you can change it. Even if you want to 8 millimeter perspirability ablation, you can do it also. Then flap stability is much better, and biomechanics, of course, are much better. But what are the advantages of microchrome? First thing is it's economical to buy and very space saving. For femtosecond is a big machine, you have to require more space. Then initial cost is very, very high. Second is economical to run microchrome because the running cost is very, very low. You can have CMC, you don't have CMC, doesn't matter much. But femtosecond, you have to pay huge amount for CMC also. Then economical procedure. Here you are using blades, while in femtosecond you have to use PI, which are given much costly. It may be 8 to 10,000 per eye. So that's an additional cost. So if we consider the economics, microchrome makes much better sense because it's very economical and you can do all the procedure. Femtosecond is a better alternative to microchrome, but it's not essential to start initially. Refractive results of both the procedure are very good. It doesn't matter in femtosecond or microchrome, they are almost same. Elliptical flaps now with newer microchrome like SBK, you have elliptical flaps also. Then with newer microchrome, the flaps, they are almost planar now. It's not perfect, but it's almost planar now. So you're getting much better flaps what we were getting earlier with earlier microchromes. And visual recovery is little early in microchrome because here in femtosecond we have used energy. It takes few more hours, but that's almost same. So what is happening when the femtosecond provides us a lot of benefits to us? Microchrome technology has also improved a lot. We are getting much quality better microchromes now that provides us much better quality of flaps also. So the flaps are now planar also there. You can have the elliptical flaps also. So some of the advantage of femtoseconds are already there in microchrome technology. I think in coming future will be a much more better. So in what is happening? This I have already covered. So what is happening? There's an improvement in every section of refractive surgery. We are having surgical. The PRK was much neglected earlier. Now we have got advanced surface ablation. It's a new avatar. It's a much better film. Microchromes have improved a lot. Femtosecond laser has improved a lot. I think SMILE is also again improving a lot. Newer companies are coming. They are coming with better machines. So some of the limitation of SMILEs, they are also taking out. So nothing is going out. Everything is going to be stay here. So my advice is, if you are going to start a LASIK center, especially for the budding ophthalmologist or the young ophthalmologist, where finances is a big problem once you start a new center because your revenue is not there initially. So basic things you require is excimer laser, you require a pachymeter, you require a topographer, then you start with the microchrome. And of course, once you come in, your practice starts picking up, you can always add other things. You can add femto laser, you can add SMILE if you feel like. So these things can be added later. So these are the basic things. I think microchrome is the best choice for a budding surgeon or for an ophthalmologist who's going to start LASIK center. So it gives you peace of mind, relax, earn first, then grow big. So you start, the theme is you start slow, small, and then grow big. So that's all I just wanted to say. Thank you. Thank you very much.
Thank you so much, sir. Thank you so much. An excellent talk. I would like to bring in Dr. Himanshu sir and Dr. Vardhaman here. One question that we all have is that how many percentage of patients come to you and demand a femtosecond laser rather than you deciding what is the choice of flap creation?
Vardhaman, over to you.
Yeah, thank you, sir. I think first of all, I think thanks to the youthful IIRSI and our very young president, Dr. Himanshu sir, for the kind invite to be here. So I think it is a very pertinent question. I think it depends on a lot of factors, but I think in today's generation of patients, they are very well aware and they are quite updated. So I will say that more often or not, they are already aware about what all technologies are there in available in India or abroad. They also are aware which hospitals have which kind of technology overall. More and more people are definitely coming and asking for specific technologies to us now, including Smile or Contura. But what is important for us to actually understand is that it is not what the patient is asking for. You have to actually understand from the whole analysis what technology should be the best for that particular patient. So maybe if the patient is coming and asking you for a smile procedure, but if you feel that compared to smile, maybe doing a surface ablation is better procedure for him, then this is something that you have to really work upon. But definitely, I think more and more patients are coming. If I have to put in percentage, I think in my setting, I will say that almost 70 to 75% patients are already aware about all techniques and already inclined towards one or the other techniques before they have come to me. Yeah.
Yeah. Thanks, Vardhan. The answer is very clear on. This is an internet-driven business, more or less. There are all those people who have read a lot and they want to do the cheapest possible thing. So there is somebody who is advertising that blade free. He's doing PRK, surface treatment. So it's not femtosecond. But so this is how it is. Instead of not starting, a keratode is definitely a good option to start with. It is how much confidence you have in your own self, what you can tell the patient on your own and make them aware that this is a good proposition for you. Nobody has ever lost eyes because of this. Now the newer microkeratones, as Dr. Vinod Arora was saying, getting a buttonhole is almost an impossibility with the new Moria microkeratome. We have seen a buttonhole, we have seen a free flap, but free flap is a lot more manageable than a buttonhole. The planar flaps also are better, and if you will be surprised at times to see that the flaps are actually very nice with a blade in certain cases, then with a femto. So you have to be confident and tell the patient, and of course they save money. So yes, femto, no question, would be the best answer that you can have. Having said that, don't feel extremely inferior if you don't have one, because the idea in people's mind which has been given is blade means like the razor blade or the surgical surgeon's blade. It's not that. It's a very highly sophisticated microkeratome. It's a beautiful machine. The first time I saw in the US in 91, I was bowled over that. What a lovely piece of machinery somebody has made. And so it's nice. It's excellent, and I would encourage patients. So, Dr. Arora, you agree with me that the complication rates with the microkeratome has gone down tremendously?
Yeah, newer microchromes are much, much better. So they have taken a lot of complications and we have a lot of confidence in these machines. So complication rate has drastically down. I think that's one thing. It's improving a lot and taking almost coming with at par with femtolizid. Of course, there are some advantages of femtolizid definitely. But as we are talking about the young ophthalmologists who are going to start the practice, I think their first step should be go for femtolizid. Of course, they can add up everything. If you got a lot of options, that's much better. But that requires a lot of money also. Once you earn it, your center starts earning, your volume pickups, you can add anything. But if you're going to start basic center where your volume is zero, and from zero you have to start, then I think microcutome makes your first choice. Then you can go for femtolizid, then you can go for a smile also, then other things can be added. And basically you can start with a simple topography machines. There's a lot of things there, tomography, topography, and a lot of things are coming. But these are very good. This helps you in few cases. But once you are going to start, you have to look for the finances also. It's good for busy surgeons, like surgeons who are doing for years. They can have everything. They can provide you everything, and patient loves option also. But sometimes it's not on the other way also. So if you get one thing, you will stick to that thing. Once you build up your practice, then naturally you can keep on adding everything. You can add a femtolizid, you can add a smile. That comes on the second stage. That's my take-home messages.
Hi, Gaurav. Good to see you.
Good to see you too. Good to see everybody. Yeah, sorry I'm late.
Yeah.
Stuck in traffic.
So, sir, the question was, now, in fact, I would like your perspective also from a tier 2 town point of view, that how many percentage of your patients actually come and ask you about the way you create your flap, whether you want to do an NK on them, or in fact demand an FS from you?
Rohan, is that directed to me?
Yes,
Or,
sir.
okay. So the thing is that nowadays patients who come to us are mostly already, they're looking for something, they don't walk in saying that, please tell me what all kinds of LASIK are there. They've already done their research and they come, many of them have researched about Contura. So most people have researched the net, they've done research Google, they've done YouTube, and they're already influenced a lot. And it becomes very difficult sometimes to, educate them about a procedure which they might actually be eligible for or maybe better for them. So they would come, and if so many of them come asking for Smile, for example. Some people come asking for Contura LASIK. Some of them even come asking for all laser PRK and stuff. So frankly, I think today's patients are mostly quite well educated and aware, and they are researched. So I think the total profile has changed. Till about 5-10 years back, people didn't know what LASIK was. They used to wonder, what do they actually do? They had no concept of a laser correction, frankly. So you have to tell them that we are going to do this, and they used to think that we are going to put a lens in the eye, which you have to tell them ki nahi, lens kuch nahi lagega and all that. Now it's totally changed. Now the patient who comes to you is fairly well educated about what he's looking for, and sometimes it's difficult to change their mind as well.
Yeah. So, sir, your solution for a youngster, how would a youngster who cannot afford to straight away put in all these machines, how does that youngster deal with a patient like that?
So Ron, I think I'm sure you guys have discussed this before, but I think it's foolish to actually put up a machine yourself today. In our times when we started doing, myself and Dr. Arora started doing LASIK, there was no LASIK machine in Dehradun, and not even from here till Delhi. And so there was no choice. If we wanted to do refractive surgery, some of us had to get together and put together a machine. Today, I think every city has LASIK centers which allow people to visit, which have machines. It is no longer economically viable to put up a machine for your own center unless you have a practice where you're doing like 50 LASIK patients or 100 eyes minimum per month, because the logistics and the cost of running the machine and everything is so much. And frankly, with the number of machines available now, break-evens, I would think that only 20%, and maybe I'm exaggerating, 20-25% centers will be breaking even or in profit. So it's probably more useful for any youngster to not invest a penny on a LASIK machine. Just have the diagnostics and utilize one of the many centers which may be allowing them to go and operate and learn how to operate. And when you have a reasonable volume, maybe you're doing say 10, 15, 20 cases a month, then think in terms of putting up your own machine. There's nothing wrong in that. Once you're doing great, you can always put up a machine. But to begin with, it's more economically viable, less pressures, and very sensible, because otherwise you buy a machine and you don't have the numbers, you are loss making, there's so much stress, and I don't think it's a good thing.
Yes, reminds me of the photograph that Dr. Arora had put right at the end of his talk of a baby sleeping calmly when you haven't invested.
Absolutely.
Yeah.
In a big town, I think that's a very good thing. Like somebody in Bombay doesn't even have to think twice. Bombay or Pune, or for that matter, any of the big cities, you can just visit one of the centers, pay them their fee and use their machine. It's so much better.
I think the problem is in smaller towns.
Yes.
Here we have got limited ophthalmologists, and people are not willing to share, or people are not cooperative that way. Sometimes that can cause problem. Otherwise, sharing is the best option. Nothing like that.
Absolutely.
Great. So we'll move on to the next topic. I'll ask Dr. Anshika, please, to introduce Dr. Vardhaman.
Thank you, Dr. Rohan. So our next speaker is the director of Asian Eye Hospital, Pune. Dr. Vardhaman is the first Indian to undergo a one-year fellowship in advanced refractive surgery from Greece, from the father of LASIK and EpiLASIK, along with another fellowship at Bascom Palmer Eye Institute, Miami. Dr. Kankaria has won many national and international papers in various conferences and has many publications under his hands. Dr. Vardhaman has also been a pioneer in teaching many students under his fellowship program. Here we have him to tell us about choosing ideal technology for the ideal patient. Over to you, sir.
Thank you very much. Am I audible?
Yes, sir.
Thank you. So first and foremost, I would like to thank the entire committee of Youthful and RSI, our president, Dr. Himanshu sir, Dr. Gaurav, and Dr. Arora sir, everybody who is here. I think it's a great platform for all the youngsters to gain knowledge at the beginning of their career. Wish we could have had something like that. And I think Dr. Gaurav's also brainchild that has brought in such a amazing venture. So friends, as we had this like a preemptive discussion about having your own setup or not, I think I would really agree with Dr. Gaurav when he said that it is better that instead of investing on your own, you can take access at variety of centers. And one of the reason I will say that is also highlighted in my talk is basically then you can have actually variety of technologies under your belt and you can choose the best patient for the best technology and probably take access for the technology and then do the surgery for that patient. So this is precisely what I'm going to talk to you about. So friends, we all know that refractive surgery of today is a dream realized. These are definitely the surgeries to eliminate and decrease dependency on glasses and contact lenses. They have become very big 5 to 10 minute procedures. They are currently completely leadless, now also flapless with smile, with a great amount of wow effect. And the recent IIRSI survey has demonstrated that the satisfaction index of this procedure as a lifestyle modifying surgery has been the highest amongst all the elective surgeries, which is close to 97%. So refractive surgery has actually clocked almost a century, if you really see, because the first ever posterior RK, which was done in Japan by Professor Sato, was back in almost 1920, and now we are in 2020, 2021. So in this almost a century journey of refractive surgical different innovations, you have seen that there are a variety of technologies which have actually come. Some of them have stood the test of time. Some have actually have managed with the journey, with time. However, now as we stand today, definitely now there are a variety of technologies that we have as armamentarium. And the thing that we have to understand, and I would like to make this mainly for also our young surgeons who would like to become a refractive surgeon, that if you want to do a refractive surgery, it is not that you become a LASIK surgeon. I think if you want to be a true refractive surgeon, you should be able to have understanding and expertise about variety of technologies which are there and customize the decision for choosing the best solution for that given patient. Just to give you a couple of examples, this was one of the patient who was referred to us for the post PRK haze, as you can see. Although the laser was done on a good machine for not very high diopter, but the patient was actually a policeman, a traffic policeman. So with a very excessive exposure of sunlight, he underwent PTK with mitomycin C, and as you can see, he has actually done pretty well. But these are the kind of scenarios that we should try to avoid in our patients. Again, another patient who is an athlete was a football player, but after about 3 months of his femtoLASIK, had a small injury, and you can see here he has a very small displacement. So he required a flap reposition, and now he's of course doing pretty well. So it's very crucial that we don't stick to only one procedure. We actually understand what is best for our patients, and this entire armamentarium is something that we should understand now, which includes corneal laser procedures, which involves microkeratome LASIK, femtoLASIK, now also topography guided femtoLASIK procedures, smile procedures, and advanced surface ablations. When it comes to lens procedures, we have to know the phakic lenses, phakic lens implants, and those minority of patients where nothing else is possible. A minority of these people can be still helped with refractive lens exchange as well. So when it comes to my protocols, I stick to corneal laser procedures for myopia less than 9 diopters, hyperopia less than 5 diopters, and astigmatism less than 5 diopters, if the corneal parameters are deemed suitable for such a laser vision correction. As we all know, current laser vision correction technologies can be flap-based, including the microkeratome LASIK, femtoLASIK, or Contura, or they can also be flapless, such as advanced surface ablation or smile procedure itself. So, going further to decide on which technology to use for this patient, if the patient already has an excellent quality of vision, has very good nighttime quality of vision, and does not have significant aberrations, definitely the different optimized platforms of today are excellent solutions that can be achieved with even LASIK, with microkeratome as well, femtosecond and LASIK, advanced surface ablation, as well as with SMILE. But if you see the patient does have a lot of abrasions, especially coming from the cornea, there is a topographic asymmetry or astigmatism that you see, then a topographic guided treatment is truly a great solution for these patients to have. And I think different guided treatments overall have died down as far as the choice of procedures have concern, and they have been taken over largely by the topography guided treatments now. For patients who are not deemed suitable for corneal laser procedures, especially for people who have more than 9 diopters of myopia, more than 5 diopters of hyperopia, with, of course, with possibility of having good anterior chamber depth, or the patients who have probably lower metropias, but the corneas are not suitable for lasers, uh, and have enough anterior chamber depth, phakic lens implants are a beautiful, beautiful solution, one of my most favorite procedures to perform. And if the anterior chamber depth is insufficient, then of course the refractive lens exchange becomes one of the scenarios. For myself, what I do is SMILE has become my procedure of choice and first choice currently, with all its advantages. So a common or typical patient when he comes with this kind of myopic astigmatism, which is, let us say, moderate, with very good corneal parameters that we are looking at, my first choice will be SMILE. Why SMILE currently? Because we have seen that the SMILE actually is a great marriage, and the advantages of both advanced surface ablation in the form of being flapless with slightly better stability, and the advantages of the lamellar procedures in terms of the fast recovery, completely penless course with less amount of regression and no possibility of haze, has made SMILE as a great solution for majority of our patients. Especially today, when you have a lot of people who are computer users, they already have some pre-existing dry eye. So SMILE obviously becomes a great solution here, because in SMILE, as you know, you are actually taking out the lenticule from much below the subepithelial nerve plexus, thus preserving the corneal nerves much better than with LASIK, in which you will be actually creating a flap. You will be creating a flap and then
I think Dr. Rupal has to probably mute herself, ma'am.
Yes. So basically, as we see, because of these reasons, there is also less induction of corneal neuropathy and much better preservation of corneal sensations with SMILE. If you look at this study, which was published by Dan Einstein, in which he has actually compared 16 studies of LASIK and about 7 publications from SMILE, and he has shown that after LASIK, there is a sudden drop in corneal sensations, which goes to less than 10%, and it takes a long time for it to recover. As against in SMILE, actually the corneal sensitivity reduces by only 30 or 40% initially, and also is known to recover much faster. This corneal sensitivity restoration is also reflected by improvement also of your dry eye parameters, both objective as well as subjective parameters, having seemed to recover much faster with SMILE. That's why for majority of my patients currently, my choice is SMILE. So let us say that for patients who have 1.50 to 8 diopters of myopia, especially if they have a pre-existing mild dry eye, and of course, if they are in contact sport, I would like to go with the flapless procedures. Current patients in which I avoid to do SMILE are patients who have low myopia of less than 1.50 diopters. Of course, patients who have hyperopia, we cannot do SMILE currently, but patients who have pure astigmatism or very significant astigmatism more than 2.50, I do not choose to do SMILE procedure on them, such as this patient. So look at this, one of the patients who was a 28-year-old, 25-year-old male patient who came with this myopic astigmatism with a very nice symmetric bow tie, but high astigmatism, as you can see here. So in such key patients, I have actually seen that the results of topo-guided femto LASIK are actually better than with SMILE procedure. Similarly, if you see this girl who has a pure astigmatism, in this case, of course, performing a SMILE, performing a topo-guided treatment will be the procedure of choice, especially for patients who are hyperopic. Hyperopia is especially important when it comes to take a call, basically because as against any other LASIK, femto-LASIK, in topo-guided femto-LASIK, the hyperopic ablsions are going to be bang on the visual axis. So that's why the issues with angle cover and other things don't happen, and hyperopic treatments are always best treated with topo-guided treatments. So, of course, there is a role of femtosecond LASIK procedures as well as mechanical microkeratome. Overall, if you ask me in general, femtosecond lasers are definitely my preferred choice of flap making as compared to mechanical microkeratomes. Mechanical microkeratomes of today are absolutely excellent, as we have seen with the talk of Dr. Arora sir. And we do use it for many patients who don't afford femtosecond LASIK. And especially I use it over and above femtosecond LASIK if there is a pre-existing corneal scar, because the femtosecond lasers do not penetrate the corneal scars very well. So this was just to give you an example of hyperopia. So in hyperopia, when you treat with the topography guided treatment, the treatment is going to be more on visual axis, and that is the one that gives rise to much better quality of vision. So my indications for topo-guided treatments are people who have myopic astigmatisms more than 2.5, people who have hyperopia, pure astigmatisms. Of course, I avoid it on patients who already are prone to trauma because of occupations such as being in police or if they are in defense, patients who already have pre-existing significant dry eye, and of course, patients who have epithelial basement dystrophy because that can lead to much higher chance of epithelial ingrowth after the flap creation. Now, those are other minority of patients who are not deemed correct for lamellar procedures, and those are the people in which I take advantage of undergoing having surface ablation procedure. These people are typically when I'm not very happy with topography. So when the topography is not abnormal, but it is certainly some yellow flags, or you have a mildly variant of normal topography. These are the kind of patients where I would not like to create a flap. There are a variety of studies which have actually shown in contralateral eyes that eyes with similar topographies when have undergone PRK versus LASIK, the LASIK eye has actually ended up having ectasia. The PRK eye, even after 10 years of follow-up, actually have continued to give good outcomes. So this is another patient who has this inferior asymmetry, fortunately has low myopia. So these are the patients in which I would still go ahead with the advanced surface ablation. Again, this patient has excellent thickness, as you can see, but I'm not very comfortable in doing a lamellar cut on patients who already have these steep corneas. So in this case, the cornea is overall okay. There is no posterior elevation, but the corneal steepness is about 49 diopters. So again, these are the people in which I would like to still go ahead and perform a surface ablation procedure because it is less invasive. Of course, you're going to come up with certain people who have more than just a minor variation topography, such as this patient who is already a suspect keratoconus patient. If such a patient comes to you, it is very crucial that you first look at the stability of, to look at overall how is the situation of the cornea, look at least 6 months follow-up to see that it is not really worsening too much. And if it is 6 months to 1 year fairly stable, then you can perform what is called as a PRK extra procedure, in which you do an advanced surface ablation with a half fluence cross-linking, provided that you are not ablating on the cornea too much. And we have, I think, almost a series of now almost 86 patients with such topographies in which we have done PRK extra. There are decently good outcomes, and none of them have developed full-blown ectasia. Is there a difference between the way you do advanced surface ablation if you're doing it with PRK, MMC, epi-LASIK, or LASIK? So we had published a study back in 2014. This was almost a 3-year follow-up study of patients who underwent contralateral surface ablation, different protocols, and we have seen that whatever method you are happy with, whether it is LASIK, epi-LASIK, or PRK, MMC, the outcomes are going to be fairly similar. So indication for me to perform advanced surface ablation is typically when the corneas uh, are near normal, but there are minor yellow flags there. If you have a steeper cornea, if you have a minorly thinner cornea, but I don't go beyond 6 diopters currently when it comes to advanced surface ablations, especially for people who want to go to defense and army. Of course, this becomes one of the procedures of choice. And patients who have pre-existing dry eye, this is another possibility for them as with smile procedure. Of course, you have to rule out that the patients are not keloid formers, so you have to ask about the history of their healing after any injury. And there is no stem cell deficiency, such as people who have had long history of VKC, and of course, occupations prone to UV exposure, such as the police officer, the traffic policeman that we have seen. So this is another very interesting patient we had seen the other day. You can see the patient came with six vision with -3 diopters of spherical error. And what we have seen is vision was excellent, topography was good, but you can see that there are signs of epithelial basement dystrophy. So these are the people you should avoid to cut a flap, including smile. You should not cut a lamellar cut. You should always go with surface ablation because surface ablation will also treat this epithelial basement membrane dystrophy. So for those patients who are not suitable for corneal lasers, as we have discussed before, of course, the lens-based solutions are excellent. Phakic lenses such as ICL are outstanding solutions, and I think for even young surgeons, I think probably they are very easy for you to learn. You should, if you become well versed with phacosurgery, it will become very easy for you to perform the ICL procedure. So this was another case report our team had published, in which this was like a 9 or 10 years of follow-up for patient who had -9.75 diopters of spherical equivalent, had one eye LASIK and one eye star ICL. So when the patient came back after 9 years, in the eye, which had basically he had regressed to -2 when he was not very happy about quality of vision. As against in the other eye of ICL, he was still able to see 20/20, 30, 20/30 to 20/25. That patient was very, very happy with the ICL in long term. So, of course, when would you choose this option is for all the people who have very high emetropia, such as in this patient, or patients who have relatively lower emetropia but thinner cornea. So this cornea of 480 microns, but emetropia more than -7 diopters is due for phakic lenses. Again, coming to this eye, which is in which we have seen that the patient has very thin cornea. It's like 458 micron cornea was already suspect keratoconus. We have to look at the overall stability of his cornea over 6 months or 1 year. But if everything seems fine, then he is a great candidate again for phakic lenses such as ICL, IPCL, RIL, whichever is the procedure of choice for you. 1 second. So basically, there are a variety of lenses. We have had opportunity to use each and every of this phakic lens, including ICL, IPCL, Actrel, as well as RIL. All of them are great solutions. So whichever your patient can afford, you can go ahead and implant them. That's not a problem. So there are also minority of such people who have emetropia beyond 20 diopters, which is the range for your EVO ICL. So if you have a emetropia which is well beyond those 20 diopters, such as in this case, the spherical equivalent is 22 to 24 diopters, either you can go with the Indian phakic lenses because those are the ones who will be able to accommodate such a high emetropia, or you can perform what is called as a bioptics procedure in which you do the star EVO ICL along with either LASIK or SMILE, whatever is your procedure of choice, in phased manner, in which first you create a flap, you perform the ICL on the same sitting, then you wait it out for another 2 weeks or so, refract the patient again and perform LASIK after about 2 weeks time. So this is the procedure which has been used a lot in the US, especially because till the time the toric ICLs were US FDA approved, for all patients who had high emetropia with astigmatism, they used to do the spherical ICL with the astigmatism correction by LASIK procedure, bioptics. So again, coming to people who are beyond 40 years of age and who don't have enough anti-chamber depth, refractive lens exchange becomes a great solution. This is an interesting case. You can see the patient had very high, so this patient had high myopic astigmatism. Patient already had suspect keratoconus, was low anterior chamber depth of 2.67 millimeters, and had also multiple lattice degenerations in both eyes. So I think this is just to make you understand that some of the patients you have to learn to reject. So it is not necessary that you operate on each and every patient that comes to you. You have to learn to reject patients. So this is one of the patients in which you would not like to intervene, probably do barrage laser for him, follow him up for the future, and make sure that you do not intervene for this patient. So in conclusion, I would like to just tell all the young doctors that as we discussed, it is not necessary that you buy all these equipments yourself. I think it is necessary you have your own diagnostic tools with you. You have to have access to these technologies, but you have to learn all these technologies so that you are able to give the best possible solution to your own patients. So these new techniques have really made a spectrum of refractive surgeries much wider, much more accurate, and customizing the decision is what I would like to really stress on. I would like to thank again IRSI and also the youthful wing of IRSI for giving me this kind opportunity to be with you today. Thank you so much.
Thank you so much for your wonderful talk, Dr. Vardhaman. Taking off where we left off before your conversations, we mentioned that on the earlier days, patients used to come with after researching on the net. But how do you convince them in case they need another choice of procedure for the refractive power?
Yeah. So I think, as we discussed in current times, this is a very relevant question because more often or not, if you are especially in your metro, these patients will come to you with certain preconceived notions that they have. So you have to spend more chair time with them for sure because they already have certain very solid concepts in their minds that they are not very easily willing to change. But you have to spend time with them. You have to make them understand by like as compared to what they are wanting to undergo, why this particular procedure is better for them. So this has happened with us a lot of times because, for example, if somebody has come for SMILE and has very, very high astigmatism, let us say 3.5 diopters of astigmatism. So we tell them that if you're very keen, we can still perform SMILE, but of course the accuracy of treatment will be much, much better if you undergo topo-guided frontal LASIK procedure we also tell them and show them certain times evidences from the literature showing that this is how we choose our patients. So the patients have to believe that whatever decision that you're taking for the patient is in their best interest. And this is one of the other reasons that you should be well versed, or all young doctors have to be well versed with all technologies, because otherwise the patient will feel that because there is only one technique or two techniques in the hospital, this is why you are kind of forcing him to undergo only one technology over the other. So yeah, but you have to spend more time with those patients and show them some proof of evidence.
Thank you so much. I'd like to ask Dr. Rupal ma'am, she's just joined us, for her comments on how does she go ahead and choose what technology to use, for a particular patient in a particular case. Dr. Rupal ma'am.
Hello.
Yes, ma'am, you're audible.
Yeah. So thank you, Rohan. And I'm sorry for joining in late. What I normally do is try and see which one would work the best for them, and then try and counsel them in a way where I'm leading them to choose that particular procedure, if it's going to be the one which is going to work the best for their requirement. So it's very easy to actually make a person know what is good for them if you sincerely believe in it. And then you should actually spell out the pros and cons of what would otherwise the other techniques where it would have limitations, in case you feel that a particular technique is the only one that should be used in that particular patient. Now, that's not the case in most patients. Most patients can do well with even 3 or 4 different types of techniques. And it would then boil down to whether the person wants the safest procedure, whether they want to make sure that they get the perfect result, or whether they want to go in for something which is the in thing to do, or that somebody else has been very happy about it and then they want to do. So then you can just give them all the pros and cons of each and every technique, and then you should then allow them to choose, and then they choose it depending upon their budget, their knowledge, their requirement. So I actually leave the decision on the patient. I only drive them to a particular procedure if I feel that that particular procedure is the best way to go for that particular patient.
Pearl of wisdom, then customer is the king. So Dr. Nikhil, if I may.
Yeah, Rohan.
Yeah.
I would just say this, that it is very important what you are confident of. Your body language will reflect that. If you haven't done a particular procedure well, you're not very confident, you will not imbibe that kind of confidence to tell the patient that you're going to be doing that. So you be very sure what you are saying, and you can always lead the pathway. Leaving it to the patient, after explaining everything about every multifocal, Gaurav will also admit, end of the day, they know what to do, but they're going to tell you, Doctor Sahab, aap jo kahenge wo. They'll pass on the buck to you. They very easily pass on the buck to you. Your call, doc. So tomorrow they can blame you. They have decided, but they want it from your mouth. So you walk into that trap very easily. And that's exactly what they want. You walk into the trap. They nahi, Doctor Sahab, aap hi decide kijiye. Sab sunne ke baad, so either their neighbor has made the decision for them, somebody whom they are close to has done this procedure, nahi, I want this only. That's how it works. Or what you are confident with. And with Dr. Rupal Shah, so she decides whatever she wants. No questions asked. Nobody dares to ask her questions.
I think there's one.
You really think so?
I think there's one more way. I just tell the patient that every eye is a unique. It's not a standard item where we can give a one procedure to all or one size fits to all. So your eyes is special. It's a unique one, and we have to give the best what is possible for your eyes, not for other eyes. So if a patient wants a smile, if a patient wants femto, if a patient wants say phakic or anything. But what we think is better, we have to tell them this is the best suited for your eye. Now it's your choice if you want to have it or you want to go for what you have heard here. So I think most of the patient agrees on that. I say the doctor should be the deciding one. Unless you got a similar options, then it's okay. But once you don't have a similar option, suppose a patient is good for a smile, then we have to tell and ask, motivate him to go for a smile only. It's not that we can just leave it to the patient to go for that. So we tell her your eyes are unique. It's a special one. It requires a special treatment, and that this is the special treatment for your eye. So then the patient gets convinced most of the time.
Okay. So Dr. Nikhil, as a young ophthalmologist just entered into refractive practice, how difficult do you find convincing a patient at this age?
It all depends, Rohan. If the patient is already driven towards it, if the patient comes, there are a lot of patients who are already driven to get rid of their spectacles or something, then it's pretty much easy convincing them for a particular procedure. But yes, there are yet a lot of patients who convincing would be slightly tougher at this age, as compared to someone who's way more experienced. When they give the word, then they're much more convinced. But yes, if you do put all the facts, tell the patients what are the worst things that can happen, tell them even what is the, that this can be, what are the different complications, how they can be handled, and keep everything clearly on the table, then definitely, yes, they do get convinced at the end of the day.
Okay. So last words on this, Dr. Gaurav sir.
So I think we've heard it all, and it's all what it echoes my thoughts as well. But I think what most of us have agreed upon is that, coming upfront, clear, and having confidence in what you're doing, these are the two keys. And of course, if a patient is making a wrong choice, then it's always good to, kind of educate them on that. But excellent talk by Vardhaman. He kind of made things so easy to go through. So I think the message is loud and clear.
Thank you all. We have our next speaker, Dr. Sonu Goel. He is the director of Anand Hospital and Eye Care Center, Jaipur. He has more than 20 years of teaching in ophthalmic practice and is the top anterior segment surgeon in the country. He specializes in complicated cataract and refractive surgeries. Dr. Goel has also had many fellowship programs where he teaches them phaco and refractive surgeries. Being a certified surgeon for ICL implantation, we have him on our show to help us take the leap for ICL implantation. Welcome to the show, sir.
Thank you, Sonu, for being there, my dear friend.
I just, I'm in the middle of my OT. I'm so sorry for making things so late. And at the outset, I'd like to thank IIRSI and the Young Brigade, everyone here, Rohan, Pooja, and I just forgot Gaurav's daughter's name, wonderful young girl. So thank you so much for making me here. And yes, I was just listening to all the discussion. So I think for me, one key point, one key message, I think every patient, tests your confidence. How much confident are you in delivering the good to that patient? And yes, if you're confident in, speaking to the patient, assuring him of the results, I can bet on it, the patient would never buy Dr. Himanshu, but he would always buy Pooja and say, yes, Pooja, I want to get it done from you, not from your dad, whatever the experience might be, because I can test your confidence and you sound really great and wonderful. So I think that is one take home for every youth in India. Be confident in whatever you practice and you'll have your day. So I do not have any financial disclosures. So the spectrum of refractive surgery, I'm very sure Dr. Rupal Shah, Vardhaman have really come up very well. And the spectrum of refractive surgery, basically I divide cornea-based and lens-based. And sometimes I combine in my practice whereby addressing high myopes, I would do something on the cornea and the rest on the lens, and I would do away with all the refractive error that the patient has. Gaurav and me and Dr. Himanshu have been practicing for the last 20, 30, 40 years. And yes, we have given those patients endless results with wonderful refractive outcome. So phakic intraocular lenses, as the history tells us, have been there in the market, varying from the angle-supported lenses where we had the Kelman or the Ecrisoft lenses. Then came in the iris claw lenses. We have seen a lot of these Verisi lenses, artisan lenses, Veriflex lenses. And I think for the young generation, they would always see those dislocated lenses lying in the AC rather than themselves doing those iris claw lenses. And then came in an era of posterior chamber lenses, which is called the ICL or the implantable collamer lenses as we call them. So why the posterior chamber concept came in and why this is in vogue in the present day scenario is basically they stand behind the iris. They are far from the endothelium. So far from the endothelium, saves the cornea, saves the endothelial damage. They have an excellent cosmesis. So even if you have a candlelight dinner, the lenses really don't shine. So they are invisible to a naked eye. They are as close to the nodal point. So we usually have the patient saying, I see better with these lenses than what I could see with my glasses, because you get some amount of magnification factor because of this physiological phenomena. There is always a gain in the retinal size image, and that what makes these patients see better what they were seeing with the glasses, and a greater effective optical zone. So that translates to a better night vision at the corneal plane. So they are located in the sulcus. So that's a very stable location lying in the sulcus and causing less of the uveitic phenomena earlier with the anterior chamber or the iris supported lenses. They're easy to remove or exchange. We have been seeing that these lenses can be easily removed with the same forceps injecting the viscoelastic in the anterior chamber. They do not require any fixation into the iris, and you do not alter shape or remove the cornea. So your cornea remains virgin, and at the same time, you're treating the refractive error of the patient. So the phakic IOL for the youngsters, I would say, to begin with, when you sound economical, you can have these wonderful Indian intraocular lenses by the IOC and the Biotech, and they work equally well. And if you are a practitioner where the patients can afford, Star is one of the great products that we've been using over years. So preoperative assessment, a good patient selection, and a lens calculation is what is the key for your practice. And I can, bang on this that every young surgeon who is doing a cataract surgery can become a great refractive surgeon just on the practice of an ICL. You don't require great tools. You don't require those fancy Visumax or the laser equipments or the femto equipment. You just require a good microscope, a preoperative workup, and you can always commit yourself to be a good refractive surgeon. So the right candidate is what is required. We all know that when we have a practice where, it's not a busy practice and you get very few patients, usually you will end up getting those patients who have been rejected by multiple surgeons. So be very careful in choosing the right candidate when you're doing the first few phakic IOL surgeries. A clear cornea, age more than 19 years, and at least a 1 or a 2 year refractive stability. The patient, you have to see to that the patient doesn't have any systemic illness, any connective tissue disorders, diabetic, and there is no fundus pathology. So off late of these myopic patients that we have been dealing, we have made it mandatory to screen these patients on an OCT. The macula has to be screened because usually they are high myopes. So age, as I said, 21 to 60. You have to check out for the refractive stability. The anterior chamber depth that I'll be talking later is usually more than 2.8. Now, this is one very strict principle which we all should adhere. I would not go even to 2.79. So 2.8 is my cutoff from the endothelium when I talk for the anterior chamber depth. The angles, yes, you all should do a gonioscopy, and the angles should be open, grade 3 and grade 4. Patients, ideally, in the initial, when you pick up, they shouldn't have any previous ophthalmic surgeries, especially the corneal refractive surgery, and no previous ocular pathology, and where the cornea should be clearly ruled out for Fuchs dystrophy or a low endothelial cell counting. If you have access to a specular count, I think this is one very great tool which you should do. Off-label indications, to start with the refractive surgery, you shouldn't attempt the off-label indications because you might get a lot of those patients, keratoconus patients or keratoconus suspect, which have been rejected for refractive surgery, who might come to you in your chamber demanding for a refractive surgery. So be very careful. Off-label indications could be after penetrating keratoplasties, DALC, intracorneal rings, or keratoconus where we have stabilized by cross-linking. In kids, we have been doing ICLs where you have high anisometropic patients, and in pseudophakic patients as a piggybacking procedure. Strict contraindications for patients who have a pre-existing glaucoma, cataract, uveitis, or any other ocular pathology which could interfere with their visual acuity. Monocular patients should be avoided in your initial practices. Narrow angles and definitely small anterior chamber depths are a strict no-no. Always assess these patients after dilatation, because a lot of these times, these high myopes could have zonular abnormalities. They could have subluxated lens. or sometimes ciliary body abnormalities, where you could end up in some disaster. So the recommended ocular examination, I would again say a very good history taking, a refraction, which is both manifest and cycloplegic, a good anterior segment evaluation, where you are doing a good pupil and a palpable aperture, slit lamp examination, the anterior chamber configuration, iris topography, cornea and the lens evaluation, and the measurements on different equipments. Now, these measurements basically boil into two major investigations that we are worried for: the anterior chamber depth and the white-to-white assessment. Now, this boils basically to calculating out the sizing or the size, what ICL you would order. So the ICL sizing after the refraction, once you have the refractive error in your hand, you would boil down to calculating out the anterior chamber depth. And the anterior chamber depth, for me, if you do not have any equipment, you could even use it on an ultrasound, the A scan that you have, but you need to calibrate that calculations of this. So the anterior chamber depth, I would always talk on the endo. ACD endo means from the endothelium to the anterior surface of the lens. And the two most common the tools to calculate, the most reliable would be the pentacam, and the second would be the IL master. If you have an access to an IL master or an op scan, or if your colleague has, I think there is no shame in getting these patients done from a common center in your initial practice if you do not have an access to these equipments. A white-to-white can easily be calculated out by using a digital caliper, which is not a very costly tool. And this can also be correlated by using an IL master or an op scan. Gone are those days where we were really calculating out the sulcus to sulcus by using a UBM. It is a too tedious job, but now I think the nomograms that we have with the digital caliper, it gives quite an accurate results. The angle assessment, as I've already mentioned, using a gonioscopy. And if you have an access to a specular, yes, a specular count shall always be done. And an OCT macula should always be performed to rule out if there is any kind of an occult CNVM in these high myopic patients. So what actually this sizing boils down is what is called as the vault. So this vault is basically the distance between the posterior surface of the ICL and the anterior surface of the natural lens. So this is what we are aiming at after getting a good sizing. An adequate vault would be somewhere, I just missed out that slide. So an adequate vault would be somewhere between half the thickness of the cornea to maybe 1.5 thickness of the cornea. So 250 microns to 750 microns. Though recently the ICEs that we have a central hole, and these are called the V4C models, and these are quite sparing when we are talking of the low vaults, because they usually give you that normal physiology of aqueous flow, and hence the cataract formation in these subsets of patients, it's quite low when we have a low vault. So a quick comparison of the anterior chamber depth using various equipments. Usually the pentacam works for the best, and the IL master and the op scan usually have a difference of almost 0.2 when we're talking of the anterior chamber depth. So the white-to-white initial cases, I would recommend you to take these patients in your OR, put a drop of xylocaine, put a speculum, look under the microscope, take the digital caliper and measure this white-to-white under the microscope. Because with this, you'll be able to judge exactly where the limbus is. And in case if you have doubt, you can take multiple readings, both horizontal and vertical, compare both the eyes. And if in case there is a gross discrepancy between the two eyes, you should check on a different equipment. So as I mentioned, white-to-white on an IL Master 700 could give you an error of 0.3 millimeters as compared to a pentacam. So I would trust the pentacam the best when white-to-white and the anterior chamber depth calculation is done. So this is what I was talking about. An idle vault would be somewhere between 250 to 750 microns. An undersized ICL where you have a vault less than 125 micron vault, and this is usually risks the patient for an anterior subcapsular opacification, and an oversized ICL is usually more than 1,000 micron vault. And these are the two extreme of the conditions where you really have to think in and going either a step up and a step down when you are doing a sizing, and you really need to exchange the ICL. Recent, there has been a thought on the lens rise. What exactly lens rise means, if you draw a horizontal line across the lens and you see the vertical height, this is what is the lens rise. And this rise is a measure of actually the distance between the line from the angle to angle, and then is measured on a fixed point in the anterior chamber. So there are a lot of points taken in where you are considering when you see the surprises once the lens goes and sits inside the anterior chamber and you feel that the vault is slightly shaky. One of these factors could be the lens rise. So if the rise is less than 600 microns and the anterior chamber depth is greater than 3.2, there appears to be a very low risk of pigment dispersion or a touch. Now, once you have taken the refractive error and you have calculated out the white to white and the anterior chamber depth, your data goes to the manufacturer, whichever you want to implant. And this is how the size is calculated by them. So if I talk about your corneal white to white is 11.15 and the anterior chamber depth value comes to around 3, the lens they would order you is a 12.6 millimeter size lens. Now, the surprises comes when you are dealing with the extreme of the conditions. That means if you have a white to white of 11.64 and you have an ACD value of 3.3, now between 11.64 to 11.65, the lens size can vary one step. So these are those patients where you really need to figure out what vault are you looking at. And in cases of toric ICLs, I would always go one side up because I really want the lens to be stable in the anterior chamber and not a lens which would give me rotation day one. A quick word for the material with which these lenses are made up of. We know the the ICL is made up of a polymer material. Polymer is basically biocompatible. And to me, I would say over a series of almost 15 years that we have been doing, we have hardly seen any abnormal reaction in the anterior chamber. So these lenses are very flexible, and whenever you try to explant these lenses, even with the same forceps, you just go in, pluck it, and you can just push it out. So very soft, biocompatible material, and no flare and no cellular reactions. And it is because of the fibronectin layer which is coated on it, which makes it biocompatible. A quick word of the IPCL lenses, and this is the product of our own Indian companies, and this is the IOCare. And these lenses, if you see, they have another multiple holes, and which give you further control on the vaulting that they have. They usually have both for myopia, the toric lenses, presbyopic lenses also, and the presbyopic toric that these companies usually have. Biotic is another great product, and we've been using of late these lenses. And these are made up of hydrophilic acrylic as against the polymer lenses. And they also work equally well and with very great stability of the toric lenses in the anterior chamber. Now, once you have these lenses implanted, the two most important intraoperative, I would have loved to show the intraoperative surgical videos, but because of the shortage of time, I would not really impinge into the time. But I would just like to touch two great points. The incision size, in my experience, is what is very important. You exactly have to have a 3 millimeter incision whenever you are doing an ICL, because the injector delivery system with a 3 millimeter incision snugly fits into it. You do not have an injector delivery system which is really shaky. Either it goes more in the anterior chamber or it gets off the anterior chamber. So exactly the incision size of 3 millimeters is what is I target. And delivery system, once you have in the anterior chamber, you can either use a sodium hyaluronate or you can use methyl cellulose. And in my practice, methyl cellulose works well, and both these can be easily washed off. Be careful when you're doing these lenses, because in cases of cataract, you're directing the lens posteriorly. That means towards the posterior pole. But whenever you are doing a phakic lens, your direction always has to be towards the opposite clock arc. That means I'm not directing the lens vertically down, but I'm going just straight and directing my pressure towards the opposite angle. Now, that is the way by which you can prevent any damage while injecting these lenses on your normal, the phakic lens that we have. So once you have implanted these lenses, they can be carefully tucked in. You have to have the day one picture where you really need to find out the vault, and the vault can be calculated out by the OCT that you have. Even if you don't have an access to an OCT, good experience on a slit lamp can make you access what is the vault, and you can just compare by the thickness of the cornea to the gap between the ICL and the normal lens that you have, and this would give you a fair idea of the vault that you have. So 250 to 750 is normally, or maybe half the thickness of the cornea to 1.5 thickness of the cornea is what the vault that we are aiming at. So low vault, yes, can cause cataract. And I said 125 micron, less than that, you should seriously think of exchanging one size higher. And a high vault, maybe more than 1,000 micron, could end up your patient with secondary glaucoma or increased risk of iris pigmentations. So you really need to, if you have a non-toric ICL, you can just rotate this lens vertically, because vertically the internal ACD is more than the horizontal, and this could get back your lenses to a normal vault. But in case of a toric ICL, you really need to exchange these lenses with one size lower. So with an IIRSI, you can have, if you have access to an IIRSI, the toric misalignment can be calculated, but this can also be calculated out by simply seeing on the slit lamp, and you have those online multiple toric apps which can give you a fair idea of the rotation of the ICLs. So a quick word for the troubleshooting, because this is, what people come to me asking, and specifically the young population where you have the trouble. So a high vault, if you have a normal IOP, just leave the lens as it is, just observe. But you have a high IOP and your chambers are shallow, you can just put shin viscoelastic and rotate the lens vertically if it's a non-toric lens. But if it's a toric lens, you need to exchange one size lower. A low vault, and if you have no peripheral touch, in case of a V4C, just observe this lens. But if you have a peripheral touch, still you do not have any cataract, you can still observe in cases of V4C. If you have an early non-progressive opacity coming up, still you can observe with a V4C. But if you have a cataract which is progressive, you need to explant or exchange one size up. So this is a quick troubleshooting in cases of both the extremes of the vault that we have. There have been the lenses have been explanted, and the most common complications during these surgeries have been the cataract. And yes, there have been patients with glaucoma, early intraocular pressure rise, but be careful, because this cataract formation usually is most commonly reported as an intraocular complication. So whenever you are pushing a lens inside the eye, you have to just see that you are doing in a normal physiological patient. It's not a pathology that you're dealing with. So the causes of explantation, as I said, have been commonly the cataract, endothelial cell loss, corneal decompensation, and sometimes you can have dislocation of these phakic intraocular lenses as well. So thank you very much. Paucity of time, I would definitely sometime on a different platform like to share the surgical videos, the quick tips, and maybe some complications that can be encountered by the young generation. So thank you very much once again for making me a part of the show. And I would like to congratulate and boost up your energy. Each and every one of you can be a great refractive surgeon. If you do a good cataract surgery, I think a refractive surgery based on phakic IOLs is much simpler and much easier than any of those surgeries. Thank you very much.
Thank you. Thank you so much, sir. Just picking up from that note itself, just one question. When someone wants to transform from a cataract surgeon to doing your phakic IOLs, is it recommended that you first do it on dummy eyes, or if you are a prolific or if you're a good enough cataract surgeon, you're good to go straight away on the eye of a patient?
So straight away, my answer was that I never did it on a dummy eye. And yes, I did it under monitorization. There was somebody standing behind me for my first surgery, because what is more important is the loading, which is very important. Once you have loaded, you can, do it under the microscope. You can release the lens. Don't push it inside the eye, but you can just monitor under the microscope on your patient that the lens is going in the right way that you want. They reload the lens and then try to do on your first patient. So I think loading is the essence, because you just want the lens to unfold in the right way inside the eye.
Right. Thank you so much, sir. So, Dr. Anshika, I would like to just bring you in here. Just one question. Is there any exposure that you get to phakic IOLs during post-graduation?
Dr. Rohan, so while we do have all the preoperative investigations that are required for it, and it can easily be implemented, but sadly we don't get any exposure during PG, except for the one odd patient that we get to see that walks into the OPD. But ICL implantation is not a procedure that we get to learn or train for. Probably we require a fellowship for more exposure after this, but
Oh no, if you're getting late for surgery, patient on the table, please leave. Thanks for your time. But otherwise, we'll grill you more.
No, I'm still here for another 10 minutes because these young brigade has really helped me. I was to open up and I requested them just one surgery and I'll finish. No worries. I'm here for 10 minutes.
Great.
So any questions to me? Yes. And I can see Gaurav, you know.
I was a very excellent talk that you gave. I really enjoyed it. And I think what you said was absolutely correct. Doing a dummy lens and then loading it and then learning how to load it and then injecting it and watching under the microscope how it unfolds and how it can occasionally twist and, can open upside down or, those things are all possible with the ICL. And that's what I think is the key to, otherwise it's a straightforward procedure. And of course, there's more to it than just injecting it and implanting it because post-op you've explained so beautifully. So excellent talk there, Sonu.
One message.
You really loved your talk.
Oh, thank you, ma'am. One message that I would like to share is maybe last year before the COVID, when we had this ICL user meet, maybe somewhere in, I think, Gaurav, you were there, Paris. So there we were seeing a lot of these young Chinese doctors who were doing great numbers of ICL. And they were sharing with us that in China now they have those ICL clinics. So they do only cataracts and only ICLs. They don't do any other surgery, no third surgery. So I think why not in India with you as youngsters, why don't you push in hard and start, with cataract, you can all do great ICL surgeries. And with low diopters, maybe as low as -1, 1.5 that we have been practicing now to maybe as high as -18 diopters. So why should you look only for smile centers or maybe excimer centers? I mean, each one of you can have your own clinic, which is a great refractive center. It is just the confidence that you need to usher inside you, and maybe any of those centers anywhere in India which are practicing great numbers, just observe and start with a big goal.
So no, you're right. I think China sells about maybe 50 or 100 times more ICLs than India as far as STAR is concerned. Is that right?
Correct.
I mean, remember the numbers. They were probably like 50 or 100 times more than
every time they have those 10,000, 20,000 surgeons doing great numbers in a year. So China bags all those awards. I think it is maybe because they have a lot of those myopic patients. And secondly, because of those clinics that they've started. So I think this is one great strategy that we could do.
Because their refractive market is very active. So they've been doing even other types of refractive surgeries in hundreds.
Dr. Rupal, they do 100 smile procedures in one OT in one day. I was amazed. I visited one of the centers where they are doing 100 smile cases per day.
They already have high volume
on one machine.
And therefore, it's an easy ad because then you can also tackle these higher myopes and places where you can't go on the cornea. In India, price is definitely a limiting factor. So as the other things like patient's compliance and also not everybody has suitability for undergoing an ICL because the anterior chamber depth also is not always enough.
I think there are two reasons. Once we started ICL, earlier it was reserved for LASIK reject patients only. So we started doing ICL like those cases where LASIK was not done. Now it has come in the forefront. Second, some patients have stigma for putting a lens inside the eye. So LASIK is almost invisible. So they think, don't put a lens. We have to convince them very well that it's not a routine lens surgery. It's just like a film we are putting inside, which has a power. It's not a lens in such. So many of the patients have a stigma for lens also. So we have to explain them.
Also, I think people who are in contact sports and all, there is a risk if they have an ICL in their eye. So you cannot underestimate that also. Yes. Because these are all young people. They are also going to be in a very active life, and ICL does pose a limitation in that sense.
Right.
as compared to a corneal surgery.
And Sonu, I think I would agree completely when you said that Pentacam is probably the best, because I use the Pentacam for my white to whites other than the calipers. And, you know, between the Lenstar and the other machines that we use, or all the other, you know, devices, even the IIRSI, the white to white, even when you're measuring manually, like, you know, when you're using the calipers on the machine rather than going by what it automatically decides for you, even then, I think Pentacam somehow has come out to be the closest to my measurements using the calipers. I don't know how the others here feel.
I second your thought, Gaurav.
Yeah.
So, and a second question that I wanted to answer for these young, I mean, they say that we do not have an access to equipments. We can't buy a Pentacam, we can't buy a topographer when we have started in our initial practice. I think for them, getting these patients to one big center, getting it investigated and then operating, I think that works well. So why do you want to invest in the first go? So I think a group practice among 8-10 people where they have a common access to a diagnostic center, and then, you know, pulling in and sharing it, I think that should do good for, you know, when you're starting your practice in your early days.
So thank you so much, sir. Thank you so much for your time. It was a pleasure. It was a great talk. We'll move to the next talk now. Dr. Rupal Shah, it's a pleasure introducing you, ma'am. She needs no introduction. But for those who are new to the show, Dr. Rupal is the director of New Vision Laser Center in Baroda. And laser. She's an excellent teacher and has had over 1,000 ophthalmologists to do their first LASIK and SMILE under her guidance. We all have heard from her previously, and it's an absolute pleasure to have you on the show. Over to you, ma'am.
Thank you, Rohan. I really would like to thank all of you, Rohan, Pooja, Anshika, Dr. Balkrishnan, I don't know your name, but all of you, I think, Nikhil. So wonderful what you are taking, what you are doing as an initiative. And I'm really very happy to be a part of this wonderful seminar that you have organized at the youth wing of IIRSI. So I would be talking about why SMILE. And this is for people who don't know what SMILE is doing in an eye. As you all know, eyes are the ones which smile the most. And a real smile comes from the eyes and not just your mouth. And so it is very important to know about this new blue-eyed boy, which is there in refractive surgery. And the younger people, especially, you should know how to expand your field of refractive surgery by adding this new procedure, which has its own advantages. I am a consultant to Carl Zeiss Meditech, and I had this opportunity to help in the development of this particular procedure. So what is SMILE? SMILE is small incision lenticular extraction. It's a new paradigm for performing refractive surgery. What it involves is cutting out a lenticule within the corneal stroma using a femtosecond laser, and then subsequently removing it from the cornea using a small incision. The dimensions and the shape of the lenticule confirm to the refractive error to be corrected. So if I were to describe the SMILE procedure, I'll just show you a small video. This particular procedure is done with a femtosecond laser. Right now, only one company has the market of SMILE, but I'm sure that soon other laser companies will also come up with SMILE-like procedures. Here what we do is, this is creating the posterior part of the lenticule followed by a side cut. This is followed by an anterior pass of the femtosecond laser, which is separated from the posterior part by the amount of refractive error that you need to correct. And this ends in a small incision. So it basically involves 4 passes of the femtosecond laser, 2 in the planes and 1 vertically to cut the lenticule borders and 1 ending as a small incision. So total 4 incisions, 4 passes of femtosecond laser. Then you can open this small incision, approach the anterior part of the lenticule which separates it from the overlying stroma. And you can see how nicely you can separate it. This is followed by the posterior part of the lenticule being separated from the underlying stromal bed. I'm purposely showing you a very old video just to stress that the separation is and always have been quite easy. Today, it's even more easy because we know the optimum parameters for the laser energy, which would help you to not just get a quick vision recovery, but also a very smooth procedure getting done. And once you have both the surfaces separated, you can simply grasp this particular lenticule just at the edge of the incision and remove it from there, followed by a wash on the surface and also a gentle stroking of the anterior surface, which allows a quick recovery the next day. Most times you don't need to go in the interface and wash it, but this ironing is important, leaving the cornea smiling back at you. And it was in 2006 that Professor Secundo and Bloom performed the first 250 eyes in their respective clinics. And they showed that the procedure was feasible, was accurate, but the visual recovery was too slow to compete with LASIK. We at the Center for Sight New Vision Laser Center, Vadodara, started this study in August 2008. And so far we have, this is a little old figure because it's been 13 years now and the numbers are many more. So if you look at the timeline, this is how it went. So in the 2010, the first commercial sales took place. By 2018, more than 1 million procedures were done. And in 2016, the US FDA approval also went through. The remarkable aspects of SMILE are the predictability, accuracy, and stability of the treatment, which has changed only a little since our very first study, even though many aspects of treatment has changed. Now we have much better energy and spot parameters. There is a different scanning pattern, which was suggested by us because when we started doing it was a reverse of what it happens today. And that was the cause for a delayed visual recovery, which could then be solved. A higher frequency of lasers meant that there were no accumulation of bubbles and therefore a quicker visual recovery because there was no distortion of tissue. And today we have better surgical techniques, better instruments, and you would find that more than 98% of all eyes that you treat are within plus or minus 0.5 diopters of the intended correction, which is remarkable because that's what you want after a refractive surgery. And this is not just us who is saying that. There are a number of studies done all across the world. One of the studies done by Kemaya et al. Showed that 100% of the eyes were within plus or minus 0.5 diopters at 6 months. We ourselves had 95% of our eyes within plus or minus 0.5 diopters at 6 months. And these were the first few eyes done in the world without any nomogram adjustment. And we were using at that time the slower lasers, which were available at 200 kilohertz, but with a new scanning pattern. At Denmark, they were doing mostly high myopia at that time, and they also showed of the eyes within plus or minus 1 diopter at 3 months. And why is it so? It is because corneal reshaping, when you do a procedure like SMILE, is happening without the help of an excimer laser. So you are using only a femtosecond laser and no excimer laser. Excimer laser has its own limitations because it works by a principle of photoablation. And you know that photoablation rate can increase linearly with fluence beyond a certain threshold. This results in a scatter, especially for treatment of high myopia. The photoablation rate also depends a lot on the depth of ablation that you're doing. It depends on the corneal hydration, the humidity, the organic vapors in the environment, and so on and so forth. What happens in SMILE is that only a femtosecond laser is used, which uses cutting instead of ablation, which is a binary process instead of a linear one. So either it cuts or it doesn't cut. There is no little cut or no cut. And much less influence on any external factors, which also means that you have a more accurate results. How about inflammation? Since you are making 2 passes of the femtosecond laser, does it cause more inflammation? It was found that total amount of energy input into the eye with SMILE is even less than with femto-LASIK, which results in less inflammation and a very high stability of treatment. And there was a very interesting study done at Singapore, where they showed that when you do a SMILE procedure as against a LASIK procedure, whatever depth you are working on at, so whatever number you are treating, it's going to have the same amount of energy incident into the cornea. So whether you are treating 3 diopters or whether you're treating 9, unlike in an excimer laser where you would have much more energy input in a 9 diopter case to be treated than a 3 diopter case. Here, because you are making only 2 passes and a side cut, the energy incident is the same. This also results in a very high safety margin. We compared the results of in 25 patients in contralateral eyes, where we did one eye SMILE, the other eye femto-LASIK, keeping all the parameters the same, and we found that the SMILE eyes scored much higher as compared to the femto-LASIK eye in terms of the safety, even over a period of 1 year. About the stability of refraction, we found a statistically significant difference when we were treating these high myopes as compared to when you're using femto-LASIK compared to SMILE. And as you can see here, the mean for femto-LASIK and SMILE were the same because you were treating the same patient. The range was from -8 to -10 diopters. And while femto-LASIK at 1 week showed an average, the mean refraction of plus 0.11, at 9 months, it was -0.5, which is a difference of about 0.6 diopters. While in a SMILE patient, at 1 week, it was -0.04 diopters, and at 9 months, 0.2, which was a difference of 0.16, which is a significantly difference between the 2 eyes in terms of stability. As regards efficacy, we again found that the SMILE eyes scored much better as compared to femto-LASIK eyes. And regarding induction of aberrations, because that was a concern for many people, because you are not able to do a customized ablation, people thought that you would not be able to get the same amount of aberrations or you would be inducing more aberrations. What we need to understand is that this is a different procedure altogether. Here, we are not using photoablation. Excimer laser suffers from peripheral fluence losses, and that's because it's falling as an oval in the periphery of the lens that we create. Here, you are cutting out a lenticule, and therefore you can make it as you want, at whatever depth you want. And this leads to the minimal increase in spherical aberration. And therefore, and this is not shown by only one study, but a number of studies done world over, which showed that the induction of less than 0.12 microns of spherical aberration happens when you use SMILE instead of femto-LASIK. This is also part of that same study where we compared the point spread function, and you can see that the SMILE eyes have much better point spread function as compared to the femto-LASIK eye. So is the image simulation. As you can see, the SMILE eyes definitely show a better image as compared to a femto-LASIK eye. And you can see that the SMILE eyes have a true zone of whatever you have destined to create. So if you wanted a 6 millimeter zone, it was giving you a pure 6 millimeter zone, unlike in an excimer laser, as you can see here, where you would have the periphery getting lost in the zone of smoothing or a transition zone, and therefore the results are more stable, and you can also compromise on the zone size slightly, and you would still get away without any night vision issues. As regards the long-term data, SMILE shows remarkable efficacy, safety, predictability at 5 years, but now we are also doing studies at 10 years, and it's really showing the same things getting reflected. Other advantages are quite stark. There is no flap, so no displacements, less dry eyes because it's a smaller incision, less less damage to the nerve fibers and earlier regeneration. Better patient workflow because you are not going to be changing the bed or the laser stations. And it's an easier sell for patients who want a flap-free, blade-free procedure. So it's truly a pain-free, blade-free, flap-free procedure. You can do up to -10 diopters of sphere and -5 diopters of cylinder, but myopia or myopic astigmatism less than -12.5 diopters of spherical equivalent. And this is, of course, the highest margin. As we know that ICLs, IPCLs are really giving us great results, as Dr. Sonu already pointed out. So you don't really need to treat on the cornea higher myopia than this. The total thickness of the cornea after lenticular extraction, what I go as the lowest limit is at least 375 microns, which means that if I've made a cap of 100 microns, I still leave at least 275 microns on the bed. And I don't really surpass that limit because we don't really have good ways to determine whether the biomechanical stability remains good after any refractive procedure done on the cornea. We still don't have hyperopic treatment or mixed astigmatism treatment possibility commercially, but it's on the way. We've already treated a few hyperopic patients, about 100. And the results are similar, if not better than femtoLASIK in these cases, with the advantages of not needing to create a flap. If there are other ocular conditions like cataract glaucoma, of course, you don't want to do anything on the cornea and no corneal refractive surgery. If the cornea is very thin, somewhere where I would not want to do even a PRK, I would not really go ahead and do a SMILE procedure. People who have uncontrolled diabetes, diabetic retinopathy, severe dry eyes still remain a contraindication. So SMILE is a technique which has come of age. It shows across several studies remarkable accuracy, stability, safety, comparable and sometimes even superior to femtoLASIK. And in the next decade, it is likely to become the technique of choice to treat refractive errors. So all of you young ophthalmologists there, please go ahead and also incorporate this into your myopia or refractive practice, because this is definitely going to be a useful addition in your practice. All of you are most welcome to come and visit me in my Vadodara center. And we also train people. So if you need, you are most welcome to ask for help. Thank you very much.
Thank you so much, ma'am, for that beautiful presentation. So now, due to paucity of time, we're going to proceed to the next speaker, and we're going to have a combined discussion for both at the end. Introducing Dr. Nikhil Balakrishnan. He's going to talk to us about advanced surface ablation, the shift in accuracy and patient comfort. Dr. Nikhil is a young phaco-refractive surgeon based out of Mumbai. He's done his fellowship from Narayan Netralaya, Bangalore. Over to you, sir.
Are my slides visible?
Yes.
Okay. So today I'm going to be talking on advanced surface ablation. So we'll all know that PRK or advanced surface ablation was the procedure of choice in the 1990s up to 2000. But of lately, we have seen that PRK has gone out of vogue. So what are the reasons that why PRK has gone out of vogue was mainly because the haze which developed post the PRK and patients who complained of pain post the PRK procedure. So what are the causes of haze that we found post PRK? We have a lot of published literature which showed that ocular inflammation leads to altered wound healing, and also that high UV radiation post the procedure causes late onset of haze. So how do we overcome these pitfalls of PRK? Now, we in our practice, what we follow are different rituals to prevent haze. What are the different preoperative rituals? One is to treat any kind of ocular inflammation, be it meibomian gland disease. So you treat it well with by giving the patient azithromycin, copious amount of lubrications, hot fermentation. And in severe cases, you may even want to do something like a EI or a LipiFlow and treat the MGD prior to the procedure. Treatment of dry eyes and ocular surface inflammation is again very important prior to undergoing this procedure. Always check for contact lens intolerance, because if the patient has been contact lens intolerance, these patients usually do not do well with PRK. We always check if the patient has any keloids, or if the patient is on any kind of acne treatment, because again, these are the patients who are going to develop haze post the PRK procedure. Then finally, also checking for vitamin D deficiencies. If the patient has vitamin D deficiencies, it's very important to treat it first, either in mild cases, either oral by vitamin D supplements, or in severe cases by even injectable vitamin D. Now, what do we do intraoperatively? Now, as we know, the epithelium which is removed in PRK can either be done by using alcohol, it can be done mechanically, either by using a hockey stick, a spatula, or an Amoyle's brush, or you can do a laser removal of the epithelium. Now, in our study, which we conducted at our center, we found that the haze on the third day post the procedure was most in patients with alcohol removal than compared to mechanical removal, than compared to the laser removal. So patients who had undergone laser removal had the least amount of haze on third day post-op. Now, what are the in intraoperatively? Therefore, once the best method of taking out the epithelium with a laser prevents haze. And as we know, there are different modalities. You have the trans PRK, which can be done by the Schwind machine, the trans PRK, which is done by the Streamlight also. Now, in this, the advantage of the Schwind over the Streamlight is that the actual zone of epithelium removal in the Schwind can be adjusted to as minimal as 6 to 6.5 millimeters, whereas a Streamlight usually takes out the epithelium at around 8.5 millimeters. So it takes longer for the epithelium to regenerate. Therefore, patients do have pain for a few days post-operatively when patients undergo a Streamlight. Now, intraoperatively, it is very important to use the use of mitomycin C. We use mitomycin C 0.02%. Per diopter being treated, we keep the mitomycin C sponge for around about 10 seconds per diopter. Usually up to 6 diopters is the upper limit for the treatment of PRK. So maximum 60 seconds is what we keep these Merocel sponges for. Post-operatively, what we do is definitely steroid eye drops for 1 month post-operative patients. As steroids cannot be continued for long periods of time, we continue cyclosporins for up to almost 3 months. Supplementing the patient with vitamin D, as I had already spoken about. And also very important is UV protective glasses, as UV radiation is known to be one of the causes of late onset haze. Another thing is to use balanced salt solution for the prevention of pain post-PRK, both before the ablation and after ablation. It is very important to use chilled balanced salt solution, as this is known and published to decrease the incidence of pain. A study which we conducted at my alma mater, Narayan Nethralaya, was where we used Acuvale soaked BCLs, that is ketorolac soaked BCLs. What we did is that the BCL was injected with Acuvale. It was kept for 20 minutes so it got properly soaked, and then placed over the eye following the PRK procedure. Now, what we found in a study done at our center again was that the laser removal, in that the epithelial healing was much faster than mechanical and even faster than alcohol removal, because the epithelium is removed in a more organized manner, and hence epithelial healing goes on faster as compared to the other procedures. We saw that hence these patients, by using the laser, had faster wound healing, faster epithelium healing, and hence had lesser pain as compared to mechanical or alcohol removal post the procedure. Now, what are the advantages of a surface ablation over LASIK or SMILE is that the main reason why we would do a PRK is because we all know is that PRK is a stronger biomechanical procedure as compared to the other two procedures. And the reason for this is that in a PRK, the anterior corneal nerves are not traversed, which happen in both the LASIK or in the SMILE procedure. So therefore, PRK is extremely beneficial, especially in patients who have a suspicious topography, that is a very steep cornea, a thin cornea, with patients with low pachymetry. If you have a pentacam and a bad D map, patients who are showing a poor bad D or a suspicious bad D, these are the patients who you should do a PRK than a LASIK or a SMILE. Again, in a patient of an irregular epithelium, if any patients have an epithelial hypertrophy, PRK would be the procedure of choice. This is because in LASIK or in SMILE, the epithelium is untouched. Your cap or your flap is at a much deeper level. So the patient is always going to have a poor quality of vision because of the aberrations which are induced by the hypertrophied epithelium. As compared to in PRK, in which you're debriding the epithelium off. So it would be preferable that if the patient has an epithelium of almost 60 to 64 and it is irregular in different places, you can do a manual removal of the epithelium. And if the patient has a regularized epithelial hypertrophy, then you could do it with a laser. We also it's well known that because the PRK is a biomechanically stronger procedure, when you do a search, you even find that the incidence of ectasia is the least in PRK as compared to LASIK or a SMILE. Now, also, as we've already discussed in this talk earlier, people who have professional requirements, people who are in the army, navy, where they do not need a scar to be seen, prefer to undergo a surface procedure than a LASIK or a SMILE. And people who are playing contact sports, football, rugby, any kind of procedure where the flap could be displaced would do well with the PRK. So I'll just run through a few examples of procedures where we could do a PRK instead of doing a LASIK or a SMILE. So here we had a patient who was a 29-year-old patient. Here we see with a refractive error of around about 2.75. Patient had a borderline pachy of around about 503 as the thinnest corneal thickness, and also had a steep cornea of around about 46 diopters, and also a suspicious bad D. So such a patient would do well with the PRK. You can go ahead and do a PRK instead of taking a risk with going ahead with a LASIK or a SMILE in this patient. Again, a second scenario here, a borderline pachy, again of 501 thinnest corneal thickness, but I had a posterior elevation again in the suspicious range of 16 microns. So again here, the reason for which was a poor bad D again, and such a patient again, you can consider doing a PRK in this patient. And finally, any patient who has a thin cornea, a cornea of thickness of just around about 490, would again, you can consider doing a refractive error of only around about -3 diopters would do well with the PRK. Thank you.
Thank you so much, Dr. Nikhil. Can I bring in Dr. Gaurav sir here? You do SMILE as well as PRK in your practice, and we know that now there are surgeons in the country who do an only SMILE practice and an only PRK practice. So it's both the spectrums right at the end of the spectrum. So my question to you is, sir, that how do you basically, when you're doing both these procedures, as we had discussed earlier in Dr. Aroda's talk, that we were saying MK has come a long way. Similarly, even PRK has come a long way. So now, is it a better proposition for someone to go for an only PRK practice vis-a-vis what it was 5 years ago or 10 years ago?
Rohan, actually, you're right that today, because doing purely surface actually requires the most basic investment, which means just an examiner, right? So definitely makes sense for somebody who's starting out on practice and does not even want to invest on a microkeratome. And frankly, with the newer lasers, doing a pure surface practice is entirely possible today, except that I would still be reluctant to do very high corrections with pure surface, and maybe there your threshold for switching to phakic lenses could be much lower. So it is entirely possible to do pure surface, and I do a lot of surface. I really strongly believe in surface. And as Nikhil said, I've been, I started using AccuVeil about 3 years back when Narayan Nitrale started working on it, and they were publishing the issues. And, then I did the trials for the AccuSate kind of eye drops, which are also similar to AccuVeil, because AccuVeil is no longer available. And we do a lot of trans PRK last 1 or 2 years. So PRK has come a long way. We do a lot of trans PRK, and my PRK practice actually grew in the last 2 years from just about 5% to maybe 10, 15, 20%. And, LASIK now forms maybe just about a 10 to 20% part of the practice, and SMILE occupies about 60 to 70% of the practice. So in that sense, but the exclusion criteria for SMILE and LASIK are about the same, so I don't have a more relaxed criteria for SMILE at all. So definitely, if I'm not planning to do LASIK, I will not be planning to do SMILE for someone just because the cornea is either thinner or it's suspect. I do occasionally perform SMILE extra, which again works pretty well, but I switch to surface whenever I want to switch to the surface because of reasons of thinner corneas or suspect corneas. And I feel that PRK is definitely a very, very safe procedure. But there's only one catch to this. patients should have enough time to recuperate. So you have to tell them that your visual gain. See, with smile patients smile and LASIK, both patients are 6/6 or something day 1, day 2 onwards, and they're doing extremely well. So the wow factor is phenomenal. But with PRK, you have to tell them, sometimes they keep coming back to you for almost 15-20 days or a month or even longer sometimes, because the epithelial remodeling takes a longer time. So that's probably the only thing. I don't scare them about pain anymore. With PRK, good pain control, I don't actually counsel them that it's going to hurt more than anything, because they haven't undergone LASIK or smile to differentiate. And frankly, the difference is very small now with these soaked contact lenses.
Thank you, sir. Dr. Manshu, sir, your thoughts?
Yeah, PRK, you are relaxed as a surgeon, basically. Whenever in doubt, do a PRK. That's the simple answer, no question. But will you be able to survive only with PRK? If you do only PRK, not necessarily. You can pronounce that you're doing the safest surgery or the topical surgery, but you need the other armamentarium also in life. There's definitely more pain elements. Steroid response are worse patients. Rupal has seen a huge change from PRK surgery. He has seen from Rupal way back when you started, and PRK the only way going about, and then you've seen the problems, and those who have seen those problems are scared to do it.
For 1.5 years, I did only PRK, and
Correct.
I have learned so much about corneal refractive surgery simply in that 1 whole year. But as you said, it's deceptively simple, but you do have to be taking good post-op care, and you should be sure that the patient is following up with you. Otherwise, right from steroid response to haze to so many other complications can occur. So you can't really take these surgery lightly.
One patient of haze for a long time, few months, really puts you back in life.
Yes.
You lose your confidence in your own self. You haven't done anything wrong. But one patient having haze and they have gone out in the ultraviolet light, you tell them not to go out in the sun and they've gone out, or whatever, that you have to blame.
Also, you have to make sure that you have the time to follow these patients up. So you're going to be seeing the patient one visit, then second visit you operate on both thighs, they follow you up till the epithelium heals, so another 2 to 3 days. And then you need to see them at least once a month for the next 3 months, which would mean that on an average, at least 10 visits per person. And if they're going to heal normally. If they get steroid response or if they get haze, then they are going to follow you up with you even more. While as against that, if you do a LASIK or a smile-like procedure, you see them one day, operate the next day you see them, you don't know them, they don't know you after that. And that's the case in most people. And it has its disadvantages also, because when I was doing only PRK, I used to know everything about my patient, their family, their happy moments, their sad moments, their neighbors, what dress they wore in their wedding. And I used to be called for so many weddings, and those patients are getting their children now for surgery. Well, if somebody has undergone a LASIK or a smile, they see you at the airport, they look at you from far, see again, and then they would very reluctantly come to you and ask, "Oh, are you Dr. Rupal Shah? Are you the one who did the treatment on me?" And this is horrible. They don't even know you.
This is one good aspect, I mean, totally different aspect of looking at how to choose a refractive surgery and experience as a refractive surgeon, Dr. Rupal. Amazing. But I really enjoyed your talk, both your talks. I think, Dr. Rupal, you
Nikhil, you also did a good job.
Smile so well. I mean, I completely could relate to everything. And then Nikhil spoke so well, because both are very close to my heart, both surface ablations and smile, and remarkable.
I would like to just stress that each and every procedure in corneal refractive surgery definitely has some space in that armamentarium that you have. So you cannot be an only smile surgeon or an only PRK surgeon or an only LASIK surgeon or an only Contura surgeon. It just doesn't work that way, because each eye is different and each eye would have a different requirement. So you can't really, if possible, try and incorporate as many types and as many different techniques as possible. Then you will be able to cater to a lot many people and give them the best possible outcome within their limitations.
Dr. Arora, sir,
I think Dr. Vardhan has covered it well, that no procedure is ideal. You have to choose according to your patient's requirement. Everything is there in the armamentarium, and everything has to be utilized, as Dr. Rupal has said. And the recent resurgence of surface ablation, I think 2 or 3 factors are there. One was the mitomycin C, which has changed the game entirely. Second is the newer software we are getting in Student or we are getting in Alcon, where the epithelium removal has become very, very polished. Now we are getting wavefront optimized treatment of the epithelium, which was not earlier there, and which is not available with PTK. So this has changed a lot. So we are getting a very clear-cut margin, and this epithelium removal is uniform. That is making the results much more better. And people have started doing correction up to -12 also for surface ablation. Earlier, we were limited to 3 or 4 diopters. We were scared to go into 6 diopters. Now, Dr. Pavin is doing a lot of in LVP. He's doing around 12. I myself is doing 9 or 10 up to and finding very good results. Of course, the follow-up should be very, very good. And you have to make sure the patient who is using a goggles, it should be 100% UV blocker. If you ask a patient to buy from the market, it may not be 100% blocker. They may be UV glasses, but they will not be 100% blocker. So you have to make sure, you have to check it yourself, or you have to supply it yourself, and you have to explain them well. So everything is there, and depends what sort of patient requirement is there. It's not one thing fits all. So you have to choose according to the patients.
So
Thank you, sir.
Automatic C3R happens with sunlight.
Yeah.
Okay. Nikhil, I have a question for you if I'm allowed to ask. Yesterday I was dealing with a patient who has a cornea which is around like 500 and a correction of about like 3-4 diopters of myopia. And we noticed a little bit of inferior steepening on pentacam and on topography both. And when we did the OCT epithelium maps, we realized that that inferior steepening was basically epithelial hyperplasia. Inferior slight epithelial hyperplasia, the epithelium going to about like 59 microns, and the average epithelium was about 54 to 55. And that was accounting for that inferior steepening. And, we realized that it's not actually a true steepening. Yet it became a suspect cornea because, the topography maps showed up, and, it was a very big dilemma. The posterior elevation maps were fine. Everything looked good. So we actually spoke to the patient and discussed all the procedures. And then, I offered her a surface ablation. Now, one surface ablation, it came to trans-PRK versus, a Moyle's brush or whatever. And now when you want to do a trans-epithelial PRK, what do you feed? Like, you have an inferior epithelial steepening. And if you want to do like a 57 or a 58, and other areas are like 54. So, if you're going to do like 60 microns of epithelium, which my machine permits only 5 micron steps. So, it was a big dilemma. And this question is open to all the stalwarts sitting here. Should we actually do a surface ablation? If we should do a surface ablation, should we do a trans-PRK, which will remove uniform epithelium? So there's no masking, which means that, in some areas, you'll probably have more epithelium, like the epithelium will remove, and then you may have a imprint on the stroma. Or should you do an alcohol-assisted or a brush-assisted epithelium? Or should you just do a smile or a LASIK where the epithelium is left as it is? So this lady used to wear contacts till 3 months back, stopped wearing it for 3-4 months, but she continues to have a little bit of epithelial, and over 2 weeks, that thing did not change with lubricants and everything that we tried. So this is the question and dilemma.
I think if we do a LASIK or a smile, the area which the inferior steepening because of the epithelial hyperplasia will yet persist because we're not touching the epithelium at all, which would then mean the abrasions induced due to that. So the patient would not have that wow factor, the abrasions playing a role, the quality of vision would not be that great. As coming to, if you're doing a PRK, whether you do a trans PRK and uniformly remove the epithelium, or whether you do, my option would, I think, do a manual removal of the epithelium, because when it's better than uniformly removing 60, because there's a localized area. If in case it was a uniform epithelial hypertrophy all over, then I think trans PRK would be a better option in that choice.
Anybody else wants to chip in?
Yeah, agree on that. If the epi map is not very proper, or you see there is a thickening is in one place, I think it's better to remove. You get a better surface to start with. That's a uniform surface, and mechanical debridement is much preferred in these cases.
My only worry was that even if I do whatever kind of debridement, like a surface, remove the epithelium, whatever way you want, how to predict what kind of epithelial healing will happen? Will it still persist? That if inferior, see, it could be just an inferior epithelial hyperplasia for something, maybe exposure keratopathy. It could be a dry eye. It could be so many things. It's not just necessarily a contact lens warpage, which has persisted for like beyond 3 or 4 months of discontinuation of contact lenses. So if it comes back, the patient is going to still have aberrations. And, the thought was that if you probably did a smile, the patient is going to maintain the epithelium that she has always had. The hyperplasia will persist, and you correct what you want, and let that epithelium not modify your result. So it's a bit of a, at the end of the day, I was a little confused that what would have been the right choice, and I still don't have an answer. But I thought I'll share this question.
Even after LASIK or SMILE, there can still be some amount of epithelial remodeling, even if you've not touched them.
Definitely.
So, it still remains
still a very gray area, right?
Whether you should be doing that or not.
Absolutely.
I would do transepithelium and use epithelium as a masking.
So what we did eventually was a transepithelial, but what we did do was we left the cornea a little wet. I mean, I chose to do 60 microns, and I did not kind of, wipe the cornea off like I would normally do. So I did a little bit of masking so that, I was removing some of the, the hyperplasia area more than the other areas. So that way probably, I don't know.
Thank you. So just before we end, one last Kaun Banega Crorepati question. There are no 4 options here, just one option for a youngster new into the practice, low on a budget. What is the preferred practice refractive platform? All seniors to comment, please, to start with. If you have to choose just one.
Your space at Dr. Gaurav Luthra's place or Dr. Rupal's place, CSI. Go to the nearest center where you can book your place and start working. Don't give up.
I actually agree with Himanshu that first you build your practice, see how much you can do in terms of refract. See, it is not going to be as much as you would be able to do if you have your own laser, but it would give you a fair idea about your inclination, your dedication towards corneal refractive surgery. It requires a different form of commitment to time and learning and the time given to the patient. If you find that you are willing to do that, and if you have an aptitude for that, then probably it's worth investing your life saving on these expensive equipments. Otherwise, you are just making the equipment company richer, and you are going to be working for them without them paying you anything. In fact, you would be paying them more. So I really don't think it's a good idea to just jump into buying a laser if you are still somebody who do not have really a background, or nobody who would be like, shelling out the money for you. A group practice is a good idea. I see that nowadays you young guys are much more sensible. You all can get together and do a group practice, provided there is some amount of understanding and as well as honesty amongst each one of you. You could have somebody who is neutral, who is running the center, and everybody can go and use that center so that the business aspect remains out of your friendship. And of course, this option is open to go and use the pre-existing laser centers, and I think that is not a bad option.
So thank you so much, ma'am.
Everybody agrees, don't buy anything.
Yes.
It's better to have your group practice or share practice. That's going to be much easier way to enter the refractive market. As such, refractive market is quite saturated as or now. So if you don't have a volume, you can't survive because the running cost is so high that even you have invested best of equipments and your volume is not high, it's very difficult to survive in that place. You can't meet the running expenses also. So you have to make a good market survey, and to initiate yourself, first you don't invest anything from your side. Just go start practice, learn the tricks, then you see what is good for your locality or your area or your place. Then you try to decide what is best for you.
Great. So bottom line, don't rush into it.
Yes.
Rohan, I would like to add here that, first, before even delving into refractive surgery or investing into equipments or even investing into investigative modalities, I think what's most important to have is to have the right mindset for refractive surgery, which means that look at every patient and his attendant as a potential refractive surgery patient, and not that you're going to push refractive surgery, which means that don't start telling every person who walks into your clinic wearing glasses that, why aren't you getting LASIK or something like that. That's totally not done. But, start looking at potential patients who are, like every potential patient who visits you with a refractive error is, or even with a cataract for that matter, is a candidate for refractive cataract surgery. So a mindset of achieving emmetropia in every patient, be it cataract, be it LASIK, be it a pterygium, be it whatever you are doing, the mindset to give a great refractive result, be it even a dry eye, or be it even a good refraction in prescribing the right glasses or contact lenses or giving a good fit on a keratoconus patient for contact lenses, making sure that you have that, strive for that patient having that emetropia or good vision, quality vision. That's probably the mindset which you need first. And then, of course, with your existing equipments, you can always do few investigations to see and, investigate whether the refractive surgery is possible for a patient. And then I think, going on gradually investing into maybe an optical biometer, into a topographer, which add to your practice, working up every patient for refractive surgery, and then going and using the refractive surgery armamentarium at some other places, and maybe doing more of phakic lenses to begin with than laser surgery, because phakic lenses everybody can do, whoever does cataract. So, maybe threshold to an ICL or a phakic lens could be a little lower for people who don't have their own equipments. And all these things put together, and then gradually, as everybody has said, growing the practice, and then eventually maybe buying an excimer. First thing would be probably, I still feel, would not be a Visumax, Dr. Rupal, but I would still think that excimer is more, right?
More versatile.
And I do feel that even when you actually graduate to Smile, it would be great to be doing femto LASIK first, because once you get the hang of handling flaps and the dissection, you become a much better Smile surgeon. So graduating from maybe,
it has to be one step at a time.
Absolutely, starting from maybe a surface ablation with microkeratome, then in a year or two graduating to a femtosecond laser, if possible a Visumax kind of a thing, which is having the option to do Smile and flaps. But if not possible, then at least a femto LASIK, and then graduating to, so, there's no shortcuts in life, I think.
Yeah, even if you have Dr. Gaurav or Dr. Himanshu as your father.
So on that note, I'd request the organizing committee of IIRSI, Dr. Himanshu and Dr. Gaurav, to give a vote of thanks to our speakers.
I think the president does the honors.
Thanks very much, Dr. Arora, Dr. Gaurav, Dr. Rupal, for all your precious time to be here with us till late evening away from the family. And as Rohan, Anshika, Pooja, and Nikhil have done a great job for the youth to really get motivated into this. Rohan, one place where last question you said, don't delay it. The sooner the better. Get into it. You will have no choice. You will do it later. You'd rather do it sooner than later. That is my answer to most people. And very important that everybody understands the value of this. It's a part of your life, and it is definitely going to help you get more patients, because you'll get those families with you. And that's where your cataracts and the other things also will come. So thanks very much for initiating people and making them aware of the good part of LASIK surgery. The bad part is very small. We generally, we keep talking of complications, but they are minuscule amount. Don't get overwhelmed. The elephant is the happiness between the surgeon and the patient. Go ahead, get on with it. Thanks very much for the time. Over to you, Gaurav, if you have a few words to tell the youth.
Thanks, Dr. Himanshu, and all the wise words from our president. But I would like to congratulate the youngsters for doing a wonderful job of selecting the topics, the speakers, all experienced speakers who spoke really well. So, I think you guys are doing a great job, and we are proud of you. Everybody, all the young team is doing excellent. And we really feel that these webinars from the Youthful IIRSI chapter are very meaningful for the young audience. And I hope we can reach out to many more of them. And thankfully, these are archived on YouTube as well. So, it's good for anybody to go back and see them when they would like to do it. So I think continue the great work, and all the best for your future endeavors.
Thank you. Thank you so much, sir. We would like to also thank Team Microvision, Mr. Ashok and Mr. Navneet, for all their help at the back end for this event to run smoothly. Thank you so much, and see you all next month. Next month, Chapter 9, our topic is optics and the lens. Should be an interesting one.
Thanks, Dr. Rupal. Thanks, Arora sir, and Nikhil. And
thanks, everyone. Thanks.
Well done.
Good
Well
night.
done, everyone.
Thank you.
Thank you for making us a part.
Thank you. Thanks to all of you. Thank you very much, sir. Thank you.
And I would like to just chip in with a quick one, that we have a live surgery webinar coming up on coming Tuesday evening at 9 p.m. where our president is going to be showing some recorded live surgery sessions. Very exciting surgeries coming up. So please tune in 9 p.m. on 27th of July for an IIRSI live surgery webinar. And we look forward to having some exciting phaco challenging cases. So all the best.
Thank you.
Thank you.
Thank you.